Let us see how far we have come in this field with the help of AI. I would like to call upon Dr. Santosh Patil sir to take us forward through his insightful talk.
Professor of Radiology from Jain Medical College, KLE Society, Belgavi. And as you know, it's post-lunch session and it's a daunting task to defeat your power nap. So it's physiology, don't have to use AI for that. So before I begin, I would like to congratulate the team which has pulled off this wonderful event. And being a radiologist, it feels very special that they have invited me here. Thank you for that. And radiology is always one specialty which adopts technology the first compared to any other departments. And be it from the robust X-ray machines installed to the handheld X-ray photography machines which we have now, be it from the first generation of CT scan to the photon counting CTs which are in the market in the West already, and be it from local workstations to teleradiology support which we are giving, and even be it the robust MRI machines where everybody feels claustrophobic to the current day portable MRIs which will be rolled out very soon. So, and that journey from the scanner to the reading room to the patient is exactly how our session this afternoon is built. So I have been given the pleasant task to walk you all through this session. Every imaging study begins with a larger question: where does AI fit in the future of healthcare itself? So our two plenary speakers will set the stage. Mr. Chetan HD from Siemens opens this with elevating health through AI, a view of how AI is reshaping health delivery at scale. He is followed by Dr. Arjun Kalyanpur of Teleradiology Solutions, a pioneer of teleradiology in India. Rather, I should say father of teleradiology in India, on AI-enabled teleradiology. Radiology of the future. If teleradiology solved the problem of distance, AI-enabled teleradiology promises to solve the problem of time. So from the big picture, we then move to where imaging actually begins, the scanner. AI is no longer only about reading images, it's about acquiring them more intelligently. So we have Mr. Prasad from Thanu, which shows us smarter scans, how AI can reduce scan times, radiation dose, repeat examinations before a radiologist ever opens a study. So once the image is acquired, the question becomes clinical. Then comes Dr. Shiv Kumar Swami from HCG, who takes us into AI in cancer imaging, arguably the domain where the stakes are highest and the applications are most mature, covering current tools and future directions in oncoimaging. Inter-reader variability is one of our oldest challenges, and Mr. Varghese from Siemens will address how centrally trained AI systems can bring consistency and standardization in our reporting. Then Dr. Akash from United Imaging, he continues this conversation from the perspective of an imaging equipment innovator. Of course, none of this works if the human is removed from this equation. The conversation in AI has matured beyond, will it replace us? Certainly not. The real question is how we keep the clinician in the loop as the safeguard. Mr. Chandrasekhar will lecture on scalable end-to-end AI platform for ophthalmology, and our penultimate speaker, Mr. Brijesh Singh, will tell us about enabling better care for more people with AI. And finally, we have Dr. Roshan from Forus Health, who will enlighten us on unifying AI interface with robust human in the loop framework. And this brings us to the question that ties everything together. When every algorithm must ultimately answer, does it change the clinical pathway for better, faster diagnosis, earlier intervention, and more equitable access? Especially in a country like ours where radiologists to the population ratio makes intelligent triage not a luxury but a necessity. So with these few words, we are running on a tight schedule. We are already running late. And we also have two panel discussions by our eminent panelists. It's 40 minutes each panel discussions. With these few words, I would like to request everybody to strictly adhere to the timings. And it's my pleasure to invite the first speaker, Mr. Chetan HD from Siemens. Thank you.
Good afternoon, everyone. I didn't know that I would have the difficult task of waking you all up, the ones who are sleeping. Maybe if you could go to the next slide. So this would be the topic that I would be speaking about, elevating health through AI. Let's try to look around. We have heard quite a lot about what AI can do, what AI can't do, the doctor in the middle or the human in the middle, and all of those kind of topics. So I'll just continue a bit more in that space, but I also want to try to bring in some of the practicalities of what makes AI possible, what prevents AI possibilities, and how would the future look like. So maybe, yeah, the previous slide was primarily talking about the different kind of challenges that we have. One is we have a large population that is increasing, and by 2050, 2070, it is climbing up. And then we also have the challenge of reduced staff. But in additional to that, the advantages of increased computational capabilities and also the ability of high network bandwidths and stuff like that. So problems on one side, opportunities on the other side, how do we mix it together? And this is the whole crux of the talk. Currently, what you see here is exactly what I'm talking about. But most important, this is really what is driving the need for AI, not just from a patient perspective, not just from a clinical perspective, but also from the rest of the people who man the various kind of systems in the hospitals. Okay, so the most important aspect of what I want to show you is, you look at this is actually an ocean. I don't want to talk about ocean, but what I want to present is, in ocean, there are various layers. The topmost layer is where you have a lot of current, the water flows very fast, and then as you go with every depth of 5 feet, 10 feet, 100 feet, and then probably to the bottom of the ocean, you almost see that it is almost stagnant or it's not changing. Why I am trying to represent this image of an ocean is also an understanding of, do we have an understanding of how the data comes? Because we speak about a lot of AI elements, and we try to look at AI in one common way, that I already have the data, everything together, and then I'm trying to run the same set of AI algorithms. But it is not the case, because different data comes at different speeds. What you see at the top is something which is very fast moving, and it is in an uncontrolled environment. I'll come in a moment to explain what it is. And then as you go down, you have near constant data, which is also in a very much controlled environment. So when we are walking, or probably some of us when we were coming to this venue, when we were using the road, there was a lot of traffic, and then that aggravates our emotions. It also changes our cognition. And this, what happens is, if you see, it is constantly changing. And if I try to apply an AI that I have built for an imaging algorithm, would really not work for cognition, because it's constantly changing. And what it also means is that I probably need not be very accurate, because it's constantly changing. I have an ability to correct. Moving on, if I go down a little bit, there are these different kind of responses again for environmental responses related to heart rate variability, different kind of physiological changes like blood pressure and stuff like that. So these actually follow what changes in the mind. And for this again, the same AI algorithms would not apply. You need to have different kind of things. Then moving on, you have critical conditions, but then for that, we definitely have different kind of already equipments that is in place, like NICUs, and then patient monitoring system and stuff like that. And then that kind of a data, there is a different kind of an SLA with which we operate. But then as you go further down, you have the chronic conditions, and these are not something that dramatically changes. These are normally catered to by diagnosis and also through medications. And then as you go further down, behavioral aspect, I mean, this is something that we always speak about, but this is something that does not almost change unless and until there is life-changing events that happens, right? And then further down, when you go into the family history, this is already etched in stone. There is no reason that this data would ever change at all. And then the farthermost is genetics, because this is where we really have everything already encoded, almost like our Janam Kundali, if we say. If this is how there are different things that are coming at different intervals and different speeds, do I apply the same AI algorithm? Probably the answer is no. for the simple reason that the kind of systems that we already have in place, these are probably the different kind of systems that we have, and each of them are pumping out a lot of information. So my point here is, when I try to build an AI algorithm, an AI application, it's an amalgamation of all the data that is coming across at different speeds, different intervals, different conditions, and then I have to come up with something meaningful at a cost-effective manner that can then be used for the patients. Because I cannot remove the cost out of the equation, neither can I remove the criticality out of the equation, and neither can I apply a blanket statement. So many of these words and jargons that we hear more often about LLMs, SLMs and stuff like that, we have to be a bit more cognitive as to what is applicable and where am I applying that. Because this is some of the conversation that I've never heard, that I'm applying different kind of principles for different kind of speeds at which the data is moving, right? So moving on, this is one another thing. This is just the complex view of all the different kind of departments that you would have in a hospital, but the most important thing is, for all the vision that we set in place that I want to make it seamless and stuff like that, the biggest thing is, if we do not unburden the clinicians and the caregivers in the hospital by uncluttering the things, by making the systems self-discoverable, self-configurable, and to enable seamless communication, I cannot go to the vision of providing seamless and very happy experience to the patient, and while not overburdening the clinicians. And for that, I tried to dig up this image. This is again something that I picked up from Google, but the irony was I tried to really look at an image of a hospital IT department. I really could not find one. And then that also means that even within the hospitals, when you try to search for an IT department, you will almost not find. But then they are doing a heavy lifting, and the reason I'm bringing this is, unless and until we go to a point where we bring in systems between vendors, between departments, being able to talk to one another in a seamless manner, the larger vision of what we want to accomplish through AI is almost near impossible. It almost feels like utopia. So when we are able to address all of this, what can we actually do? It's just a glimpse of what we at Siemens Healthcare envision of how the future would be for the clinicians, the caregivers, and the hospital. So if you could please play the video for me.
In the decades ahead, healthcare will undergo dramatic transformations. Medicine will become more precise. Value will shape care delivery. Patients will become empowered consumers. And digitalization will transform every facet of healthcare. Patients will have a digital twin, a customized computational model of themselves, enabling Dr. Clive to anticipate illness, guide therapy options, and predict outcomes of procedures. Expanding precision medicine will enable radiologists to make highly specific diagnoses for Stephen without unwarranted variations. AI-powered decision models, fed by vast population health data, will improve diagnostic accuracy. Healthcare will become anticipatory, organized around Paula's medical conditions, and available around the clock, transforming care delivery. Multidisciplinary, highly productive care teams structured around patients and their needs will collaboratively deliver the full cycle of care. All interactions with John will become convenient, personalized, and compassionate, improving patient experience. Supported by real-time monitoring and guidance, John will become more empowered and have physical and virtual access to care when and where he needs it. At Siemens Healthineers, our mission is clear. We pioneer breakthroughs in healthcare for everyone, everywhere.
So with this, I can end my talk, but I would want to leave the stage with one last question. If you have come this far to thinking of what AI can do for us, Are we already looking at the future where we have self-healing systems? It's a very big question, but I want to leave you with that thought. Thank you all.
Thank you, sir. We appreciate your commitment to advancing medical science. So, as we know, work from home has revolutionized the IT sector and helped them achieve targets with less resources and better efficiency. A similar solution for radiologists is teleradiology. Please invite Dr. Arjun Kalyanpur for telling us more about AI-enabled technology.
Thank you very much. I'd like to thank Dr. Shiv Kumar and Dr. Ajay Kumar for inviting me to give this presentation on a topic which I'm very passionate about, AI-enabled teleradiology. And as you can see, we call it the radiology of the future, and I'll be explaining over the next 20 minutes why I feel that is the case. Now, we will approach this from the following points. First of all, look at the background of the global situation where we have a significant mismatch between the number of radiologists and the number of scans. How teleradiology has helped in the last 2 decades in addressing this problem. How AI is today transforming the playing field. Review some of the real world applications, and finally look at some of the issues that we need to keep in mind so that we use AI safely. So this is a term borrowed from my colleague, Mr. Ashutosh, who's sitting here in the audience. Crisis hiding in plain sight. This issue of radiologist shortage today is a bit like climate change. We all know it's there, but not too many people are talking about it or doing anything about it. The numbers speak for themselves. There is a staggering projected shortage of 725,000 radiologists by the year 2050. So this is a problem that's not going away anytime soon. Today we perform 1 billion studies every year, imaging studies, and this increases by 5% year on year. But the number of radiologists whom we are training is only increasing by 2%. So you can imagine that this gap is getting wider and wider. So about 3 decades ago, teleradiology, the industry started up. It was a paradigm shift, and we had the good fortune of being there at the beginning and being able to discover teleradiology as it evolved. And what we realized is that it was really transformational at every stage of the radiology diagnostic cycle. It allowed radiologists to report scans immediately at any place, anytime, anywhere in the world, 24/7. It allowed us to prioritize workflow. It allowed us to communicate immediately. Quality of reporting was increased, and radiologists were more productive. So those of you who are from the AI engineering background would see some significant similarities between this and what we're trying to achieve with AI. So it was our privilege to be able to publish and contribute to the scientific literature in this space, and we did so quite actively over the last 2 decades. The paper in the middle, though, is not by us. That's by Dr. Thrall, who was the chairman at MGH. It was one of the seminal early papers on teleradiology, which kind of set the stage for everything that followed. But of all the publishing I've done, the article that I'm probably the most proud of and excited about is this opinion piece, which was published in Academic Radiology by invitation. And I was asked to write on this topic of teleradiology and artificial intelligence, birds of the same feather, invited by Dr. Saurabh Jha, who's an eminent radiologist at the University of Pennsylvania and an AI authority himself. So in putting this article down, many thoughts emerged, and it became more and more apparent to me how closely linked AI and teleradiology are fundamentally. For one, they both address the same issue, which is radiologist shortage. They are both technology-enabled digital technologies that sit on the cloud or can sit on the cloud. They both benefit quality and productivity at the same time. And believe me, that's the hardest challenge in medicine, to increase productivity and still maintain or increase quality. So this is something very profound. Because of the fact that with teleradiology, we're getting images from many centers around the world, that means that if we participate in the AI development process, the generalizability of our data is very high. and we are able to develop technologies which have a much lower bias than those developed from a single institution. And finally, when the AI technology is deployed on a teleradiology platform, it has a global reach. So basically, it's like a rocket with a booster, and it depends on how you look at it, whether AI is the rocket and teleradiology is the booster or vice versa. But fundamentally, the end result is the same. Now, emergency radiology is something that we practice a lot in our teleradiology service, and we see some very interesting phenomena. Any of you who has watched any of the medical shows on TV will know that the ER is a place which is very active and it only gets busier at certain times. You're faced with life-threatening situations. The report has to be done immediately. All of this results to fatigue and burnout on the part of radiologists. So this is really the most challenging area in radiology. Now, interestingly, AI and teleradiology is best used in this scenario because of the combination of benefits that they offer. First of all, the spike situation is addressed by being able to provide imaging capacity instantly and improve the efficiency of radiologists. Secondly, the life-threatening entities which are mission critical, can be reported with immediate turnaround time. Communication is seamless and instant. The risk of error is reduced by the higher quality when you combine AI and teleradiology. The workflow is enhanced because you can now prioritize the positive cases. And obviously, radiologists benefit because their workload is decreased and their timing and scheduling is better. So overall, it's a win-win for the radiologists. The opportunities when you combine AI with teleradiology are significant. As we've just discussed, the biggest one is emergencies, but it can also help in remote areas in parts of the world where radiologists are not available. It's also extremely valuable in a mass casualty or pandemic situation. In COVID is where teleradiology really blossomed. Till then, there was still some skepticism, some doubt about it, but once COVID happened, everyone realized the value of being able to practice radiology from the comfort of one's home. So all of this resulted in efficient reporting at a global scale. All right, so let's look at some of the clinical use case scenarios, and all of these are areas which we have worked on in our organization. So close to a decade ago, we began to realize that teleradiology by itself could not address the shortages that we were facing and the challenges of scale that we were seeing, and that we had to develop solutions that aided radiologists to be more productive. As Dr. Patil said, teleradiology solves the problem of distance, but we also needed to solve the problem of numbers. So we found there were two areas where AI really helped. One was in the emergency setting, and the other was in the screening environment. And of course, in more recent times, we have found that there are many reporting workflow benefits that have also emerged. So we'll look at all of these in turn. And we'll start with stroke. Now, as we all know, time is brain. The issue is that from the perspective of the radiologist's brain, there is a huge challenge because there are just so many images to be seen. And over the years, as you can see from the graph on the right, that number has just continued to increase. So this is a very challenging situation for a radiologist. Probably the most challenging thing for a radiologist is stroke diagnosis and stroke interpretation. Now, we've looked at the impact of both teleradiology and AI on stroke independently, and so have a number of other researchers, as you can see from the table. And what we found is that each of these adds value. Let's look at AI in stroke. The first thing that one needs to know when a patient has a stroke is whether the stroke is a hemorrhagic stroke or an ischemic stroke. In other words, is there bleeding in the brain or is there not? Because that is what is going to decide the treatment. If there is bleeding, then you manage it with blood pressure medication and monitoring. If there is no bleeding and it's a clot, then you have to manage it with blood thinners. So obviously you can't give blood thinners if there is already bleeding. So this becomes a very important decision. AI helps us by detecting hemorrhage, measuring its size, figuring out where the hemorrhage is, and also characterizing it. So each of these types of bleeds intraparenchymal, subarachnoid, intraventricular is very effectively captured using the AI algorithm that we've built. It's particularly helpful in patients who have very small bleeds. Now, this kind of bleed is the kind which a radiologist might miss when they're busy, when they're tired, at the end of a long shift. This is exactly the kind of finding that a radiologist might miss. And a patient treated with blood thinners would come back the next day and the bleed would be 5 times the size. So this is a very high-risk situation. And you can see how effectively AI has highlighted the bleed for the radiologist to ensure that that miss does not happen. The other thing in acute stroke, as we said, in ischemic stroke, the vessel is blocked, the artery is blocked. That causes an increase in its density, and the AI algorithm captures that in the form of what we call the dense MCA, or the middle cerebral artery. This is a AI algorithm that detects the blockage in the artery by measuring the density of the clot. And finally, the AI algorithm also puts together a report which can be used as a draft report by the radiologists, further saving time in the diagnostic cycle. So multiple benefits, the trifecta of speed, efficiency, and accuracy all at the same time. But in the process, there is ability to quantify, predict outcome, guide treatment, and finally, and most important, expand access to stroke care so that today, if a CT scanner is installed at a district hospital in a smaller district in Karnataka where there is no radiologist available, we can still have a stroke patient diagnosed using a combination of AI and teleradiology. The other situation where AI is extremely helpful is head injury. India is, interestingly enough, also the head injury capital of the world. It is a huge public health issue because of the state of our roads, the state of our traffic, the issue of traffic helmets not being worn, rules not being followed. All of those reasons makes this a very serious problem for us. The AI algorithm detects findings which change the patient's outcome, the fracture of the skull or the swelling in the brain, which will determine the prognosis and outcome of the patient. So this is another area where AI can really help us in the setting of head injury. And in other kinds of trauma outside of the brain, trauma is the main cause of death in young people. So you obviously need to find the injury before it takes the patient's life. And all of these conditions are life-threatening. We'll start with pneumothorax, where the lung collapses and there is air outside the lung putting pressure on the lung. The AI algorithm not only detects it, and believe me, this is something that radiologists can easily miss, but it also measures the size of it, and which can then predict the fact that the patient is going to deteriorate very rapidly. Spinal fractures, also a situation of critical importance because the patient's neurologic status depends on it. The AI algorithm has effectively detected the fracture. Fractures of the ribs also detected with high level of accuracy by AI algorithms. These are all developed in-house in our organization. A patient with liver laceration or injury to the liver from a motor accident, you can see on both scans, the AI has outlined the area of injury to the liver. And this helps not just in making the diagnosis, but also the prognosis, because the size of the injury is what decides the results. And the same for injury to the spleen. Now, in the chest, we focused on 3 conditions. One is aortic dissection, which is a situation where the biggest artery in the body splits in 2. As you might imagine, it's life-threatening. So the algorithm that we have developed using a large sample size is able to not just diagnose the dissection, but also measure it and classify it as a type A or type B, which is what determines whether surgery is needed or not. Measuring the size of the aorta in a patient with an aneurysm is also important because the larger the aneurysm, the more the risk of rupture and fatal hemorrhage. And that is also done very accurately using AI. And in this condition called pulmonary embolism, the clot in the arteries of the lung can cause sudden death. That is preceded by right heart failure. So both the presence of the clot and the presence of right heart failure can be determined by the AI algorithm that you see here. Something as simple as pneumonia can be life-threatening in either very young patients or in patients who are already sick and immobilized, as in the ICU. Here is an algorithm that shows the pneumonia in an ICU patient, and another version of the algorithm developed specifically for children which detects pediatric pneumonias. This is extremely helpful in a rural setting where X-rays are done in an environment where there may not be even a doctor, forget about a radiologist. So the AI can confirm the diagnosis and ensure that the child receives treatment. And something as common as kidney stones, the algorithm is very accurate in detecting the presence of the stone in the kidney, the stone in the ureter, which is blocking the outflow of the kidney, and the degree of obstruction of the kidney. So those were all emergency applications, but now coming to the other end of the spectrum, which is the screening space. Now, breast cancer is the commonest cancer among Indian women, so we decided to focus our AI development in this space, and this resulted in the development of this algorithm called Mammo Assist. As you can see, it detects a series of findings on mammography, all of which are predictors of early breast cancer with a high rate of accuracy. And we have deployed this algorithm in our own teleradiology reporting platform. So it can detect either individual findings like a mass or a calcification, or a combination thereof, including findings like lymph nodes in the axilla. This is the typical workflow. It assesses for each of the findings in turn, generates a BIRAD score, which is a predictor of risk of or probability of cancer, and which it is a 4 scale grades. And ultimately, it generates a report which looks something like this. And this is extremely helpful to the clinician, both the radiologist who is reporting these studies. Now, in India, we don't have a strong breast cancer detection program, but we will soon, I hope. And in countries which do have, such as in Scandinavia or other parts of Europe or the United States, AI is extremely helpful because of the high volumes of scans of mammograms that are done, which radiologists just don't have enough time to report. And as you can imagine, this is a high-risk environment because if a breast cancer is missed, there's usually a malpractice case that follows. So this is the second part of the report, which actually captures the images and shows the findings for future reference. So these were all image analysis algorithms of the traditional kind, but today there is a new technology called the vision language model, which we found is very helpful in radiology practice. This is a new and evolving field, and so we're still exploring it. But essentially, it takes a vision encoder and a large language model and combines both of them to develop an output such as this report on the right, which is a report generated by AI of the X-ray on the left. And you can see that it's detected pretty much all the findings on the X-ray. And this can be used both in chest X-ray as well as in imaging of bony structures. This patient has a fracture of the femur, which has been correctly analyzed and diagnosed by this AI. So today, vision language models are really the AI of the future. I think there's huge potential, especially in the space of X-rays and imaging, which is single image type of imaging, where the LLM and the VLM can generate very effective reports. In general, LLMs can also be used in workflow, as you can see, for text generation. So when a radiologist is dictating a report, the LLM working in parallel with the radiologist helps to format and create report content. So the radiologist can spend less time on the reporting. As an example, think of yourself dictating, instead of dictating a whole letter, if you just dictated a few key points and the algorithm generated the text of the rest of the letter for you. That's what the algorithm does for the radiologist. That was a quick summary of teleradiology and AI, but in terms of the challenges and things we need to look out for, one is of course, as we've discussed in the previous sessions, the human is all important. The radiologist needs to be in control. And the radiologist is the person who's medico-legally liable for an AI error. So that will never change. Cybersecurity is of real importance because we are dealing with large amounts of data. So these need to be anonymized, curated, and protected. The integration with RIS and PACS, which are the workflows of radiology, is very important because the algorithms can be very good, but if they don't work in the real world setting, that doesn't help the radiologist. It may even slow them down. So the interoperability is a very important factor. Radiologists initially tend to be a little hesitant or skeptical to use AI, so there's some training, education, positive feedback that's required. And continuous performance monitoring is necessary to ensure that the AI doesn't deteriorate in performance. In summary, teleradiology allows us to collect data that's diverse and therefore develop higher quality algorithms. Close collaboration between the radiologists and the engineers is really important. We have that in our organization because we have the engineers and the radiologists sitting next to each other. And the radiologists need to keep giving continuous feedback. So when in our practice or in any radiologist practice, if you're using AI, you must continuously be giving the feedback to the engineers who developed it so that the AI continues to learn from your reporting. But ultimately, radiologists are and always must remain in charge. And finally, the benefit of AI and teleradiology integration is that it allows for global deployment of AI, which has the maximum impact and benefit. So if I were to leave you with one thought, it is that AI is essential not only for the health of the population, because it improves patient outcomes, but it's equally important for the health of the radiologists themselves, because it allows us to be more productive, more efficient, and also have a better quality of life and prevent injury and burnout. So my vision is that of the cyborg radiologist, the radiologist who's AI enabled and who uses teleradiology that is AI enabled, which is a superpower and will allow us to practice radiology more effectively and more safely to deal with the healthcare problems of the population. Thank you very much.
Thank you, sir, for showing us the scope of teleradiology and how we can use it even in AI.
That's a very informative lecture. Thank you very much. You mentioned about Mammo Assist and the BIRADS score. So you know that whenever we do mammographic screening, there is a significant amount of false positivity, and that leads to anxiety as well as resource utilization. Now, in the Indian context, majority of our patients are in the premenopausal age, and therefore their breasts are dense. So that interpretation will be totally different from what you have shown. Your comments on that?
Excellent point you made, sir. I think as with any AI, the importance of using it is to understand where it adds value and where it doesn't, or where it can potentially hinder care. So I think the AI algorithm that I showed and other AI algorithms in this space all function within the constraints of, as you mentioned, one of them being dense breasts. So I think we built into Mammo Assist a breast density assessment score. So looking at the report itself, the radiologist has some indication of how likely the algorithm is to be accurate or inaccurate. And fundamentally, sonomammography would follow in patients who have dense breasts. So that part of the collaborative workflow would still remain. So AI will be the assistant, but definitely the radiologist is still needed to ensure that the quality of care is not compromised.
So I have a question here. General Arun is my name, but I'm not going to ask you a question on how it's going to be applied in the army.
I'm sorry, I can't hear you.
General Arun is my name, but my question is not about the army or how teleradiology or AI in radiology will affect treatment in the combat zone. You identified two problems of numbers and of distance. You add to that any other problem you can think of, we'll have it. The medical technician there probably speaks only Marathi. So that language model which you develop, and so on and so forth. But my question to you, sir, is, over a period of time, how do we train the radiologist to look for the error which the AI model may probably make? Because if you are used to correctness of the AI model, let's say it's 99.99, the 0.01 error that it will make, our radiologist or doctor or practitioner may never be educated or trained enough to be able to spot. And therein lies the problem. How are we going to solve this problem, sir? That's the question.
Very good question, sir. If I may say, the first point you made, I think today we have large language models in various languages, so hopefully that issue should not be a challenge going forward in the services. But to address the question of error of AI, so typically AI errors are false negatives or false positives. False positives tend to be easier to identify because they tend to be repetitive. So in any algorithm's performance, it will tend to throw up a recurring positive which you and I as radiologists will recognize as false positives. And once you provide the feedback and retrain the model, that false positive will eventually disappear. So that is a function of retraining of the model and feedback. The false negatives are a slightly scarier challenge because ultimately if the AI misses the finding and the radiologist is too dependent on the AI, then that's where the kind of scenario that you mentioned will occur. And that's why I guess the oversight of the radiologist is always required. We can, at least in today's world, we are not in a situation where we can completely put up our feet and let AI do our job for us. I think we still need to be in complete control. We need to be scrutinizing the AI output, even for negative studies, independently to add value in the clinical scenario. And that is the only way that the partnership works. Ultimately, we are supported by AI, we're not replaced by AI, but we still need to hold our role and our responsibility very seriously. And the combination of man and machine is what makes this an effective synergy. Neither can function without the other. Hope that answers your question. Thank you, sir.
Thank you, sir, for reminding us the importance of a responsible innovation. Moving forward, let us see how AI can help improve the quality of image acquisition, which will definitely increase the chance of diagnosis and improve patient care. I would like to call upon Mr. Prasad S. Murthy for the talk.
Good afternoon, everyone. I'm Prasad Sudhakar. And even though the biography told that I am a part of GE Healthcare, I just recently moved to Tanu.ai. It's the AI Center of Excellence for Healthcare hosted inside the Institute of Science. So I used to be in GE Healthcare, so that's the reason why I'm going to talk about image acquisition and the role of AI in image acquisition. Okay. All right, so whenever we talk about AI and medical imaging, or even in general healthcare, we mostly talk about, the AI that gets used after the image is presented to the radiologist in the clinical setting, and the analysis that gets done on the images, right? But we should also remember that there is a lot of scope for AI, and which is already in place, by the way, a lot of AI that happens even before the image gets formed, right? Right from acquisition, right from protocol selection to reconstruction, denoising, whatever we want to do before the image is formed. A lot of AI gets done there as well. So I just want to throw a few examples here and show that how AI gets used even before the diagnosis or analysis is done on the images. As you know, the image acquisition is always a trade-off between multiple things, and most important of them being dose in case of CT and X-ray, and the speed of acquisition, and the quality of images that we get. So it's a three-factor balance that we need to take care of. So we need to be able to balance dose, speed, and quality. Now, in case of classical low-dose reconstruction, let's say, not referring to any particular modality, so if we have something called as a low-dose reconstruction, this is how classically it would look like. And now what we can achieve with AI is something which looks like this, which is much more crisper, sharper, and of better quality. Okay? So the same dose, same acquisition, but we do get noise suppressed, sharpness preserved, images from the same acquisitions that we have. And this is what AI is shown to be doing. Now, I'm not getting into the nitty-gritties and mechanisms of how this is done, but I just want to show a few examples. So this is what GE Healthcare has done with their True Fidelity systems, where there is a neural network that is trained on thousands of low noise FVP images, which is actually the gold standard for CT images. Now, what this True Fidelity reconstruction does is it takes noisy acquisitions and turns them into images which look like very high quality reconstructions. Okay? And this was done already in 2019. This is the first deep learning CT recon engine ever to be brought into the market. FDA approved, everything clear. Right? So it combines the classical iterative reconstructions dose capability, and it does it with very low dose acquisitions. And so this was basically the first one, but the story doesn't stop there. Well, there is also something that for MR, so GE Healthcare's Air Recon DL also does the same thing for MR reconstruction. So this is the analog of True Fidelity for MR, and it improves signal to noise ratio and image sharpness while you have shorter acquisition times. And it is shown in studies that we do get 60% sharper images with 50% shorter scan time. So this is what is available. I mean, this is used in clinics, and many a time we don't even know there is actually an AI engine working behind all this. And this is available in GE's Signia MR portfolio along with something called as AirX, which I'm going to talk about next. So before even the image is acquired, many a time we need to do proper placement of the scan plane or even the protocols to be set properly before the image is acquired, right? So AI also plays a role, and we do have something called as AirX from GE Healthcare, where the AI not only just does very good reconstruction, but also tells the clinicians which plane to be acquired. Okay? So this is done in the following way. So there is a scout scan that is done. Then there is a neural network, AI, which runs in the background, and it finds out what is the best plane to image for this particular scan, and then the protocol is set. Okay? So it supports slice planning with automated detection of the scan plane, and then it reduces the operator variability. So you can repeat the scans as many times as you want, and you're bound to get very, very similar, consistent scans. Now, this is not just GE's story, right? So this is true for many of the vendors that are out there. So every major equipment manufacturer have their own versions of these kind of AIs built in for different modalities. So for example, Siemens, I'm sure our friends here will know. So Siemens has something called Deep Resolve, which does the same super resolution reconstruction from low dose acquisitions. Canon has AICE, and Subtle Medical has Subtle PET, and all the other vendors also have their own AI engines doing this. Now, we see that there is a lot of advantage in using AI at this stage because so there is a huge reduction in the scan time, scan time, so which means that there is scan time acceleration up to 73% for Siemens and up to 50% for GE's Air Recon DL. And there is also a lot of dose reduction because of this. Subtle PET reports up to 50% dose reduction, and Canon's noise reduction is about 20%. Okay. And this is also true for other modalities like ultrasound, whereas MRI and CT, the products are already in market. Ultrasound is a bit more challenging. It's a slightly bigger beast, This is still in the labs. Many companies are working on developing very similar solutions to what we saw for CT and MRI for ultrasound as well. So instead of having full set of transmits and reconstruction from the reflected waves, people are trying to see if we can do subsampling of the transmission and then get good quality reconstructions from them. But this is a little more challenging problem, and this is still under a lot of research. So, so there are, of course, a lot of advantages. I mean, every report on every vendor claims that there is a lot of savings that we get in scan time and dose, but there are also a lot of caveats, right? Now, there is, of course, always a risk of, hallucinations. So reconstructions can give rise to hallucinations. And this is something that, the developers of this AI and the clinical teams have to be aware of, and it has to undergo a lot of rigorous testing before this actually gets into the market. Regulatory scope is narrow because this is not like build once and use it forever. So every algorithm that is built is very specific to a hardware, a combination of hardware and software. And every time a small change needs to occur, it has to be, it has to go through the entire regulatory process. And as the question was raised earlier, so radiologists need to know, not just trust. This is exactly the question that was asked before. So it's not just, we have AI giving us the answers and we blindly read the images and interpret them, but the radiologists also need to know exactly why something is happening, and that's really the challenge. So I just want to conclude this by saying that AI already decides what the image looks like before anyone even reads it. Okay? So we know that there is a lot of AI that happens after this, but I just want to give a message that a lot of AI also happens before the image is formed. So these are some references if you want, and I end my talk here. I believe there will be no questions, so I can just walk down.
Thank you, sir, for an enlightening session. We now welcome someone whose journey in oncology reflects excellence, perseverance, and innovation. Please invite with me Dr. Shiv Kumar Swami, sir, for his talk on AI in cancer imaging.
Thank you for the kind introduction. After listening to Arjun sir and Prasad, I think it's what reminds me is like whether AI is going to replace radiologists or not, but teleradiology solutions is going to replace radiologists. It comes to the crux that what Elon Musk said, stop training radiologists rather than train an AI model. Definitely if you start thinking, it's very much possible. All these algorithms what we have been training, it's very much possible that it can happen. So this was something which came in a few years back where ChatGPT cleared board exams of US in radiology. And long time ago, this was published in NEJM that machine learning will displace much of the work of the radiologist and anatomical pathologist. We have started seeing this now. It has become a reality. AI is going to be autopilot mode. Yes, this is what it is now, future, and is going to be like this, where AI will help the radiologist to make, probably we will also learn better with radiologists. This is the whole crux of AI. We have seen the clinical use case and also at the diagnostic, at the scanner level, where you can refine all the protocols, faster protocols and all that. Now with time, we definitely know that AI is going to outperform human. So this is where we are now. We are at the crossroads. And of all these methods, what we have discussed till now, I personally like the federated learning, and this is something which I learned from Siemens. I mean, I'm using Siemens equipment. I'll be showing my use case, what I do with the Siemens equipment. Federated learning is something which I really like to do, where it's a continuum, where you involve the multiple, other institutions. This was published in Japanese Radiology, whether AI revolution will let the radiologist sink or soar. There's no question of sinking. Definitely, it's going to take a big leap now. And these are some of the use case what we had done. We have seen this black box on used case where you can triage this patient, especially in an ER setup where the patient comes with chest pain, suspected pneumothorax, suspected pneumonia. Definitely we can triage these patients because the scarcity of radiologists, especially in remote places, we can do that. So this is something which we have done with Siemens, and it definitely performs better, and not just that, which also picks up the lines and tubes what we see on the chest radiograph. Coming to the oncology platform, this is an AI-read prostate MRI platform, what tool that I use. I simply load my MR study on to this platform and I continue to work on other case. So nicely it will pick up the sequences that is required to make a diagnosis as per the PIRAD scoring. We have PIRAD scoring as we have for the breast cancer detection, that is the PIRADs. The guideline says the T2 weighted imaging and the diffusion weighted imaging and the dynamic contrast. These are the three important sequences. The algorithm will pick up those sequences on its own. It will show the lesion, completely demarcate the lesion, which is definitely a learning curve for a radiologist to learn how a prostate cancer on an MR looks like. It will give the lesion characterization, what is the PIRAD scoring, and with that it will also prompt the radiologist to put additional information on a preview for the lesion on each lesions. Supposing if there are some 3 to 4 lesions, it will detect each and every lesion, and it will ask what is the PIRAD score as per your analysis. Is there an extra prostatic disease? Is there an enhancement? What score do you give? All this information is available. This is how it does, and it's not just that. If you can, yeah. When I accept that lesion detection is properly done, it not just gives the volume of the lesion, the prostate volume, which otherwise I'll have to manually do that. Everything is done, and then it generates a PIRAD scoring report. This is something which is easily done. If you deploy this kind of platform on a routine screening, prostate screening workup, most of the job is done by this algorithm. It's so user friendly. All that you have to do is you have to validate the lesions, look at the contouring of the prostate, what it has done. Of course, there's a way forward also. The federated learning, what if at all, if it starts picking up the extra prostatic disease and start giving the TNM staging, that is something which is best thing to happen. Not just that, this is the dynamic curve, dynamic contrast. When we inject the contrast to a patient, it will track the entry of the contrast to the region of interest. So in this particular case, it not just says the enhancement, but also gives the curve analysis. Like in this case, the left peripheral zone lesion of the lesion in the prostate, it shows a malignant type of enhancement. Why this is important? Now more and more prostate cancer patients, they undergo hormone therapy prior to any definitive surgery or chemotherapy. So it will also help us to do the response assessment, not just the diagnosis. It will give the curve pre-treatment and post-treatment as well. Another platform what I generally use is the lung nodule detection. Of course, in India, we are not doing active surveillance for lung cancer screening, which is basically prescribed for heavy smokers. There are guidelines for smokers, but it does decent detection of all the lung nodules. Not just decent, it is very painful to look at the lung nodules. If you start looking at the HRCT chest, it will take at least 20 to 30 minutes if you have to detect. It can detect as small as 2 mm nodules with this algorithm. I just upload this to the cloud. It will give me the complete report, including the volume of the nodule, and it can also do the comparison of pre and post, time interval grow up, volume doubling time, all that. Not just that, it will localize, it will give the 3D map on the image where exactly it is located, and not just the nodule detection, the heterogeneity of the lung, if there are any interstitial lung changes, all that information is available. As well as giving the lung nodule, the algorithm what is available on the workstation, it also measures the aorta diameter. So it will give the calcium scoring, diameter of the aorta, and it can build. So those were the days when we used to manually do all this segmentation. So now it's just at a click of a button, everything comes so nice. Moving on to next case scenario is the breast cancer. Breast MRI is now routinely performed, especially for high-risk patients and BRCA positive, family history of cancers. The lesion detection, similar to what prostate lesion detection, now it will detect clear all the malignant type of lesions, and it will also prompt us to give additional information, though it is still in the early stages. And probably, this is something which we did as a part of collaborative work with the Siemens, where it clearly defined the automatic fibroglandular tissue volume estimation. We published this in ISMRM. Of course, I couldn't go, but Siemens team did that with the AOC curve of 88.2%, which actually clearly mentioned all those information that is available. It all does at a click of a button. So with that, there's a paper which came out. What is the current scenario of AI in cancer? Clinical efficiency, detection, screening and diagnosis, lesion characterization, and also outcome prediction. So what the paper said is they did multicentric analysis, and they said the AI shows 21 to 53% reduction in screen reading time, and 20% advancement in reading confidence, and 9 to 20% increased performance of lesion characterization. So this is definitely helping a lot in a routine clinical practice. It's definitely a great tool, and I just looked at the clinical trials where AI is being used. If you see, most of the clinical trials that is on imaging, especially in cancer, is done on lung cancer and breast. That's where it is all moving. There are many other cancers that is being evaluated through AI, and their performance is also increasing. Not just that, the next step is the genomic analysis. So this is something, IDH mutation in a glioma, which now we are able to clearly give whether IDH mutant or not, which IDH mutant which happens to be in a younger population has a better prognosis than the wild type. We started giving these kind of reports routinely, telling that there is definite IDH mutation or not. Not just that, we are bringing in the genomic data as well, doing the texture analysis. All this is possible with this, though it is still not validated, but in an individual case, this is the way to go. We can predict the genomic data on imaging itself rather than going for complete analysis. This is something what Prasad spoke about, how to improve the scan time and reduce the scan time without losing the information. And this is where we are. AI can give a faster, clearer scans. It can spot the hidden cancers very easily, especially in lung nodule detection. Triaging the patients with the NLPs, we can come up with the automatic paperwork. It just picks up the structured reporting platform as well. Of course, there are challenges with black box, which most of the radiologists don't understand. There are some report generation gaps, and adoption is also an important thing, where not everyone is open to this kind of adoption. This is something that came very recently. A cancer was missed, and 5 years later, the AI detected the cancer, but the radiologist disagreed, and then the cancer was seen after 5 years in exactly same location. So this was a big thing. So that's where the AI is moving to. With that, I end my talk. Thank you.
Any questions for sir?
It's not a question, just a comment in a lighter vein. If you look at all the fatal accidents that has happened with Tesla's auto-driven cars and what the High Court or the courts have said, no radiologist or doctor will ever lose their job because of AI. Because when something goes wrong, the human has to be blamed.
Yeah, human has to be there, for sure. Thanks.
Thank you, sir, for an excellent talk. Next talk revolves around the inter-reader variability by training the algorithm using multiple data sets and also the challenges of AI. For that, please welcome Mr. Kolaratu Verghese on stage.
Good afternoon. So my name is Verghese, and so today I'll be talking about inter-rater variability and how centrally trained algorithms may or may not solve these issues for you. And I'm so glad that Dr. Shivakumar already spoke about a couple of topics I wanted to touch upon, which is federated learning, etc. So glad to hear that as well. So about me, I'm a senior key expert at Siemens Healthineers, and I happen to have a PhD after one technology institute and two hospitals decided to form a PhD degree, which is from CMC Vellore and Sri Chitra Hospital, Trivandrum. So today I'm not going to speak any specific about an AI algorithm, but I just want to talk about what happens under the hood, right? So once, let's say, a vendor like Siemens Healthineers or GE decide that they want to build an AI-based algorithm, they begin with collecting data from multiple sources so that they can overcome bias, right? Or they could partner with teleradiology company as well so that they get large amount of data and it's not centered towards a particular hospital. So this is actually, let's say, an expensive process because we need to purchase data, and more than the money part, I think it also takes time to get that amount of data because you typically also need to get ethical approvals from all of these boards. Once the data is at our end, then what typically happens is that we want to see if we can annotate the data, and in order to remove bias, we typically involve multiple radiologists or multiple medical experts, and in the event that there is a disagreement between radiologists, then we involve a third or a super senior radiologist to break the tie. Now all of this again takes a lot of time and money as well, and the money part is because radiologists are doing something additional rather than the real work over here. So it's after a lot of time, and we actually get the data to train our AI models. So once we train our AI models, we develop the model and we then validate it. Now, even when we want to validate it, typically we also have to collect data from centers where we want, or countries from where we want to deploy this, because nowadays regulatory departments are also getting stringent on saying that if this has been evaluated on the population that they cater towards. And finally, once we do that, we then deploy this globally. So what happens in a clinical setup over here is that while there are multiple radiologists doing the annotation in a clinical scenario, typically it's only a single radiologist who reads a medical volume, at most two in certain cases, but more often than not, it's a single radiologist. And what also happens is that the preference or the guidelines that the hospitals follow vary from department to department or from country to country over here. So we did a small study a couple of years back wherein we showcased around 380 lung nodules to radiologists from China and from the US over here. And the only question we asked was, which of these nodules would you end up reporting? So what you see in orange is, according to the Chinese radiologists, that they wanted around 331 nodules to end up in the report, and they felt that 49 of them need not be reported. Now, in the US, they said that it was the dire opposite. They said that only 64 out of these 380 nodules need to be reported, and the remaining ones were small. So I've just given over here, let's say, two examples of how they differ over here. Now this puts us in a very sticky situation because the same algorithm is having, let's say, different acceptance rate in two different countries. It's the same algorithm used for the same purpose, but it's just because one of them agrees with us a lot and the other one doesn't. So how do we take this forward? And we also understand that medicine as a field is also an evolving field. So today, what you consider as grade 1 or grade 2 could change into grade 1 because of the advancements in medicine over here. So that's where I wanted to bring the first option of decentralized learning or federated learning over here. So what we understand by now is that radiologists do make use of AI-based solutions in their routine workflow over here. And secondly, and most importantly, they do interact with it. So what do I mean by interact is that they either accept the AI findings or they reject the AI findings, or there is a third situation, they are not completely happy with it. Maybe they are not happy with the size estimated by the algorithm, or probably the segmentation was slightly wrong over here. So they do make these interactions. So these interactions are really good to retrain our algorithm on the fly over here. So that's the whole idea. So what we want to do is we want to invert the whole process rather than Siemens Healthineers or any entity shipping a global model. Can Siemens Healthineers or any of these entities ship the model to each site, and each site has its own local data, and they train locally at each of these sites, and it's just the model, the updated model, that is sent back to us. So the whole idea is you train locally, and once you've trained the model locally, all the local models would get aggregated centrally at this company, and then you validate it, and then you deploy it globally or back again. Now, there are a lot of pros over here, according to me, because these are data points that are trained on data arising from the radiologist. Secondly, we're not asking the radiologist to go above and beyond their real work because they're only reporting the nodules that they want to end up in the report over here. And finally, because the data stays local to the site, the patient privacy is also is also maintained or preserved over here. Now, within the regulatory framework of things, there are entities like PCCP, Predetermined Change Control Plan, as per FDA, which we could invoke to update our models. Now, while this is really good for us, what happens is that there are one of the things that does not get addressed is the personalization part. It's the same single model that goes into multiple sites. And that's where I want you to take to the second option over here. And it's just an option, it's just to invoke yourself. And this is, what if we do something very similar over here? Any entity would send their global or base model to each site. Each site has their own data over here, and they actually train and update the model. And finally, you validate the model internally over here. Now, you guys would have a new variant of your model at your end over there. Now, what I mean by this is that this AI model is highly personalized to your department, and the amount of personalization can be varied. It can be varied to a user level, to a department level, or even to a country level over here. Now, we cannot do, as Siemens Healthineers or a technology company, we cannot do it alone over here, because the number of models that we need to maintain at our end becomes exponentially higher, and it's equivalent to the number of personalization that we need. So the question is, would the healthcare department or would clinics or hospitals be ready to partner with technology companies like us and take part in the regulatory affair of things? So with that, that's my time. Thank you. If you have questions, more than happy to take.
Thank you, sir, for showing how far radiology has come with the help of AI. Let us see how we can make AI more practical, ethical, and impactful. For the next talk, I would like to invite Dr. Akash Gandhamal for his talk.
Hello everyone, very warm good afternoon. I'm Akash, so I work as a senior scientist with United Imaging Healthcare. So yeah, that's the topic of my talk today, where AI in radiology, we're redefining healthcare today and engineering tomorrow's future. So that would be the session outline where I'd be taking you through why AI and why now, and we'll see how AI is incorporated into the across imaging workflow. So I would like to introduce the UAI clinical ecosystem that we have and how it is impacting the clinical workflow, and then we are going to go all together till the building responsible AI. So why AI and why now? Because there are growing challenges in radiology. Today, imaging is not just like you have a couple of images, start reporting it through visually, but there is increasing burden onto the healthcare system in terms of the amount of images that are generated on a day-to-day basis, right from the different modalities like CT, MR, PET, mammo, and others. So that's where there's an increasing volume in images, and then again there's an increasing in case complexity, how the cases have been getting complex, more and more complex, how the imaging modalities are improving on a day-to-day basis. And at the same time, what we expect from a radiologist is the radiologist should report these cases as quick as possible. And that's where that's where the shortage of radiologists comes into picture. There's a humongous shortage of radiologists who would be able to report these images on a day-to-day basis. And again, we expect a faster turnaround times for these images that needs to be reported. Today, radiologist is not only reporting on a visual inspection, but he is also expected to report on a quantifiable manners. Everything that he reports needs to be quantified. What is the measurement? He also need to quantify in terms of the follow-ups. How, if a patient comes onto the follow-ups, how these images are getting registered, what is the stage at which the patient is. These all follow-ups are needed to be quantified. That's where the AI plays a critical role in all those repetitive tasks where there's a quantification comes into picture, where there's a follow-up comes into picture. AI would be the best solution to implement into the clinical workflow. Today, AI is not just a research-oriented topic, but it has become a necessity onto the clinical workflow. So, would AI replace radiologists? The answer would be no. AI augments radiologists because it does not replace them, because it is good at doing a repetitive tasks, but not at replacing them. So let's see how the AI can be implemented into the imaging workflow. Many have an understanding AI comes into picture only after the image is being generated, but the scenario is completely different. AI starts right at the very beginning from the patient positioning itself. The normal imaging workflow goes like patient comes in, patient positioning happens, and then the scanning protocol is decided, then the image acquisition happens, and then in terms of the image reconstruction, then the AI analysis would do in terms of the diagnosis, in terms of the detections, measurements, and all those, and then the quantification of this, and it would generate a structured report, and then the clinical would make an accurate decision based on all the analysis that has been done so far. So I would like to show a video where we have already a solution called as UAI Vision Camera, which does the patient positioning thing. Automated. The moment the patient lies onto the bed, it does the automatic registration of the patient. It auto-identifies the key landmark points and positions the patient accurate to the isocenter based on the alignment, based on the table positioning alignment and everything. Even the scanning protocol is decided automatically based on the AI solutions that we have. So that's one aspect where the AI is begin right at the patient positioning itself. And each and every aspect of the imaging workflow has a AI involved into it. So we have a dedicated UAI clinical ecosystem which fits into a clinical workflow. We at United Imaging believe that AI shouldn't be only an isolated software, but it should be a part of a clinical workflow where it would get integrated onto your day-to-day clinical workflow. So it can be integrated with all your modalities in terms of CT, MR, mammo, X-ray, PET, and everything, and in terms of all the ologies as well, right from your neurology, cardiology, oncology, orthopedics, and others. And whatever the solutions, the kind of solutions that we have, this is completely vendor neutral. It's not only the United Imaging data that's going to process, it's all the other vendor data can also be processed onto this one centralized system. And this system doesn't need any sort of a software installation that is usually required for any of the software applications that you use on a day-to-day basis. That would also support a multi-department and multi-user support at the same point of time. And whatever the solutions that we are presenting, these are all clinically validated in terms of the research publications that we have, and also in terms of regulatory approvals that we have got in terms of CE and FDA. So let's deep dive into to what ologies or to what diagnosis that we can go on to in terms of UAI. So we have a dedicated solutions for the neurology, cardiology, oncology, and also for the orthopedics. So I'd like to start with the neurological solutions, where we have focused onto the brain science such as neurodegenerative diseases. So we have a dedicated stroke protocols where we have a dedicated solution for the intracranial hemorrhage. It will not only detect the intracranial hemorrhage but also identifies in terms the presence of edema, and also auto-registers the follow-ups. Then we have ischemic stroke, which does the automatic aspect scoring. Then we have cerebral CTP for the complete perfusion analysis, and cerebral and carotid vessels for the stenosis estimation for the entire vessel reconstructions. And in terms of stroke, we also have the MR in terms of MRA, MR angio, MR perfusion, and the cerebral small vessel disease, which does the detection of the microbleeds, infarcts, lacunas, and everything. And this all solutions are completely automated, 0 click required to come out of these solutions. So we have a dedicated solutions in terms of brain science. We do a complete analysis of the brain in terms of 111 regions. We divide the brain into 111 regions and do the volumetric assessment. This would be very much useful in terms of neurodegenerative assessment. It's not only like we do just do analysis, but we also generate a complete brain health report which predicts the risk assessment in terms of the neurodegenerative risk assessment. It comes up with the MRPI score and CSVD index and everything. And we also have a dedicated solutions for the resting state fMRI and DTI in terms of a complete neurotractography, where each and every nerve is connected, and we come up with a matrix, the connectivity matrix between the connectivity of these vessels. And then we have dedicated solutions for the PET neuro in terms of centiloid scoring. And of course, we have a solutions for the brain tumor. And we have dedicated solutions for the cardiovascular diseases. So right from the imaging till the research, follow-ups and research, we have dedicated solutions for the imaging in terms of E-phase, for the accurate phase selection, and then coming up with a cardio capture for the accurate vessel reconstructions. Then we come up with the screening solution in terms of calcified, gated and non-gated calcium scoring. Then in terms of diagnosis, we come up with the complete coronary assessment in terms of stenosis estimation, cataract scoring, and also the plaque composition in terms of the amount of calcified and non-calcified component present in each plaque that has been segmented. And of course, we have a dedicated solution for the FFR, the non-invasive FFR, which would give you the hemodynamic analysis of the cardiac functioning. And then we have dedicated solutions for the cardiac MR in terms of CINE for the stress and strain analysis. In terms of emergency, we have solutions for the aortic dissection, pulmonary artery embolism, and others. And in terms of follow-ups, all of these applications are follow-up based. Even if there's a change in plaque composition over the time, if further earlier it was non-calcified, now it got calcified, how the plaque composition is changing over the period of time, that can also be analyzed through our applications that we have. And of course, we have a dedicated solutions for the research in cardiac domain as well. In terms of oncological solutions, there were many solutions who were presenting in terms of BI-RADS and PI-RADS, but in addition to that, we have a dedicated solution for the lung RADS. We come up with the automatic lung RADS scoring. We have a dedicated solution for the prostate, where we generate a complete PI-RADS report, a complete graphical based report that gets generated. And for the breast, we have a BI-RADS scoring. For liver, we have a LI-RADS scoring and the reporting of the same with the entire 3D reconstruction of the liver. And again, we have in terms of the brain lesion segmentations and metastatic segmentations also. in terms of orthopedics, we have a dedicated solutions in terms of spine disease, bone disease, and whole body system, and where we do a complete total hip arthroplasty can be planned through our application that we have developed. So what does the AI do? What, beyond detection, how it is helping the radiologist? That how AI is creating a quantitative radiology, because in a day-to-day life, radiologists are more onto the subjective, the way that they see, they report it, but AI helps in objectifying it, where the traditional radiology does the manual measurements, visual impairments, then variable there's quite of variable reporting. If you go for if you change the radiology, the report would be different in terms of the diagnosis that they make. And again, this would be overcome through the AI powered radiology, where there would be a complete automated quantification, standardized biomarkers can be designed through the AI, and then the longitudinal comparison and the reproducing of the comparison, reproducing of the reporting. If you ask a radiologist to report in the morning and ask him to report in the evening, the report would be slightly different, whereas the AI is very good in reproducing the reports. So these are the kind of solutions that we have, where you can see the snapshots of the reports that get generated for the different applications that we have. So how the AI radiologist, how is AI partnering with the radiologist? So in recent days, radiologists have started loving AI, because together they deliver faster workflow, improved consistency, better diagnostic confidence, more time for complex cases, and the better patient care. At last, AI will not replace the radiologist, but radiologists who use AI will redefine the healthcare, is what I would like to say. How the tomorrow is looking through the AI in terms of the radiology. So today's radiology or AI, it looks in terms of detection, segmentation, quantification, or a simpler reporting that can be generated through the AI. But the tomorrow's AI is more of a predictive imaging, where we have a personalized protocols dedicated for each patient, and then there is a development happening in terms of digital twins, where you would be completely digitized in terms of replicating the clinical or simulating the clinical workflows. And of course, there would be multimodal AI that would be registering multiple modalities into one aspect, taking into genomics also into consideration, and which would definitely lead to a precision medicine. So building an AI is a different thing, but building a responsible AI is what more important into the today's day-to-day life. So it should be depend on the clinical validation. It should have the explainability in terms of what the AI is generating. It should explain itself. And then in terms of the data privacy, each patient privacy needs to be protected in terms of the data privacy. And of course, there should be a regulatory compliance to come up with all these AI solutions in the market. And then again, I would repeat again, like, human oversight is definitely needed for all the AI results that have been generated. So at last, I would say AI doesn't replace expertise, but it will amplify it. And if you combine human intelligence with the artificial intelligence, it will be a great way to a better healthcare. Thank you.
Thank you, sir, for an excellent talk. Next, let's move on and see how AI is revolutionizing the field of ophthalmology. Please put your hands together for Mr. Chandrasekhar Silamantula.
So I'd like to start off by saying Sarvendriyanam Nayanam Pradhanam, which means that amongst all sense organs, the eye is supreme. And not only is it supreme, but it can also, be used to tell multiple issues within the body itself. So, okay. So this is a quite brief session outline: motivation, history, and our work. What I just want to present is the frontiers of what we are doing at our labs here today. So I would like to do a small activity where all of you just keep a mental note every time you see one of these systemic diseases that occur once, among your close relatives and family members. So diabetes, hypertension, hyperthyroidism, sleep apnea, quite common. So just as the prevalence says. So it turns out that these diseases could actually be indicators of ocular disease, and also the converse is also true. There is a lot of work that is happening in this field, but this motivation slide sort of inspires me in a lot of ways, because this shows that all of us are stakeholders even though our vision is intact. So yeah, so I guess this is a more regular motivation slide where you have about 4.95 million blind people. You have about 70 million who are visually impaired. And again, the economic burden that this places on a developing country like ours is insane almost. So to take a look at this problem from a more technical aspect is required. Yeah, so a little bit about us. So our lab, Spectrum Lab, which is based in IISc, started working on this problem back in 2015. And through the years, we have collaborated with multiple people, a prominent collaborator being Zeiss. We are funded by the Kotak AI/ML Center of Excellence. And we also have the largest India-specific glaucoma dataset that is publicly available. And this is for everyone who wants to sort of benchmark their AI in the Indian domain. So we have also conducted a symposium on artificial intelligence, and over the last 11 years, we have more than 13 publications in journals and conferences. So taking all of this experience into hand, we sort of combined that to form Chakshu AI. Now, what is Chakshu AI? A lot of people have been talking about these sort of frameworks and workflows that people incorporate into their clinical settings, and Chakshu AI is no different, but in the sense of ophthalmology. Now, you take a fundus image, you run it through multiple modes of analysis where there are many AI models that look at this one fundus image and generates a comprehensive report. This sort of is permeable at every sort of stage of medical intervention, at the PHCs, at the hospitals, and even at screening camps. So again, you can come visit us at the C2 stall if you want more information about this. But what I did want to present today is the frontiers of what we are doing with AI. So let's look at this slide, for instance. So moving ahead, you have foundation models, which everyone seems to be talking about, which I'll get into depth. Then we have vision language models, which take vision, which is basically images, and some text extracts, combine them together in some joint embedding space, and you're able to make inferences. Then you have generative AI. Of course, everyone has used this in terms of ChatGPT, but here it's going to be used in a slightly more older fashion. So self-supervised learning. This is where an AI model doesn't require any labels to learn the internal latent representations of what is present in an image. What I mean by that is we have a very large public domain of fundus images and very few ophthalmologists who can actually annotate these fundus images. So what do we do with all these images that have no annotations? Turns out you can take a self-supervised model, show the invariances that are present within these images, where the model sort of learns these invariant representations and internally learns what a fundus image is without you ever, discreetly sort of providing supervision, which is quite great if you think about it, which means that you don't need annotations to get dense representations. Then moving on to VLMs. Again, this has been spoken about quite a bit in this conference, where you have a vision encoder which takes in an image, brings some latent representations. You have a text model which takes in your text, brings some textual representations, and combines the two, which I think is important because a fundus image is quite abstract to a machine learning model, right? So when you involve text or supervision from the doctor's side, it just becomes a better internal representation of what the model actually contains. Now, at last, generative AI, which I'll get to in the end. So if you take a look at this chart, it might seem a bit boring initially, but if you take this green dot that you see there with 23 million parameters, this was a model that was trained on labels, label data basically, where multiple ophthalmologists sit, annotate images, and then you train a model. Everyone knows about that. Now, the two smaller dots that you see over there have not been trained specifically on annotated images. And as you can see, it clearly outperforms what you could do with the regular model and some supervision. And of course, that's our internal model that we use for diabetic retinopathy grading. And these two are models that we are still experimenting with. This shows truly how great a model is because even without any training with supervision, you're still able to achieve incredible results. Moving on to the next slide. So VLM. So this is what a VLM is in a more mathematical setting. And what we ended up doing is we ended up segmenting the fundus image that is present, providing dense captioning for each particular segment, and then giving that to a model. So that way it is more spatially aware of what it's looking at. Through this, you can, this sounds a bit moonshot, I agree, but with this, you can almost detect any retinal ophthalmic pathology that you can probably fathom or that probably exists. Now let's say someone comes up with a new pathology that has a few indicators. With few shot learning and almost no training, this model can diagnose that. And that's where the promise is with VLMs, which I don't think many people highlighted today. It's more about discovery rather than just diagnosis. I'd like to, have you keep that in mind. So finally, this is an activity that I would like to do. So both of these are the same image with the absolutely exactly same vasculature. So I want you guys to pick the real image of the two. We'll do this with a show of hands because I feel everyone's getting bored. But so the image on the right, how many of you think it's generative? Please raise your hands. Okay. The image on the left, how many do you think is generative? Please raise your hands. Great. This is actually great because this is my Turing test to know that we have done something right? So just so that I don't get trigger happy and reveal like that. The result is basically the one on the left is the real image and the one on the right is the generated image. Now, to just absolutely see that 50% picked one and the other 50% picked the other is like, brings joy to my heart. But what this means that this technology is already being taken to sort of an extent that we haven't seen before. I get it that everyone is sort of apprehensive of AI and people getting their jobs replaced. Honestly, I'm in the space of programming, so I think my job is going to get replaced the first. But if you look at the bigger picture, I feel that we can sort of utilize these technologies not just to diagnose or see what is wrong in a particular image, but to discover. I feel humans are pioneers and sort of letting us have these safeguards around us. I know I do understand safety is an important priority, but if we don't allow ourselves to discover what is possible, then we are sort of restricting our creativity. So I would like to end with that. This is the team that is present at HAI. If you see us anywhere, you can come pick our brains and you can scan that for our website and reach out to me or Professor Chandrasekhar Seelamantula at any time. Thank you. Yeah.
Thank you for your presentation. So as we know, our ultimate goal is patient care, and we're all here to learn how to make it more streamlined and systematic with AI. I would like to call upon Mr. Brajesh Singh for his talk on enabling better patient care.
Hi, good afternoon everyone. I am Brajesh. I head imaging business for Philips. So moving from clinical and technology, you are moving to business. So you will hear less clinical and technical, more on the trend on AI. So I'll talk on, see, our company's vision is to deliver better care for more people. How we are using AI to achieve that, that's what I'll try to cover. So many times in radiology, when we talk about AI, we talk a lot on how we are saving time, how we are saving minutes from clinicians' time, right? But eventual goal is that how we can enable the care team so that they can deliver consistently high quality imaging to every patient wherever they are treated. What it means that, can you fix the trade-off between access and the quality? That's what we are trying to do with the help of AI. Very quickly, I think all of you are familiar with Philips, but you also know that in 130 years, we have transitioned from a light bulb to a radio TV to a pure health tech company now. And in these 130 years, we have spent 100 years in India. But when we talk of this transformation, innovation has been at the core of that, right? Every year we are investing around 9% of our R&D in AI, and you will be happy that 50% of that is going into software and AI now, and 80% of the innovation and software and AI is happening in Bangalore. In our innovation campus in Bangalore, where there are 6,000 engineers working on everything that we are developing for software and AI. 80% of Philips developed software and AI happens in Bangalore. What we talk on today will be more on the trends in AI. Of course, I'll also talk about few of the products that we have. And all those trends are not something of my opinion. We do an annual survey of the healthcare leaders, which we do in 16 countries, including India. So this survey captures 16,000 people, 2,000 clinicians and 16,000 general population. So whatever trends I'll talk about will mostly refer to this future health index. But first, coming to, is AI helping, right? First we need to answer. We know that we are getting lots of data now from wearable, from imaging devices, from monitoring. Is say that now we have tsunami of data, but sometimes that tsunami may not help you, but it can overwhelm you also, which can delay the decision making. So what you need is not a lot of data, but data which comes from interconnected system, which you can convert to information, to insight, to actionable insight, right? A data where you build the intelligence in the workflow, so data becomes the insight. That's what we are trying to achieve through AI, whether it's in radiology, whether in pathology, whether in cardiovascular informatics. Why AI is required, I think many of earlier speakers have also covered, so I'll not go into full detail, but I'll try to summarize in 3 lines. We know that patient volume is increasing. We have more and more aging population, more urban population. That means that the complexity of chronic disease are increasing. There's a 5 times increase in imaging data in last decade. And all that you cannot really sustain if you don't have AI. So AI is not really a choice, is an assistant every radiologist will need to sustain the volume and the complexity. I just said that what AI does, either we have experience or we have seen others achieving that, whether it's accuracy, whether it's efficiency, whether it's workflow standardization. But what medtech company can do to scale up the AI, right? I will try to focus more on that. So one purpose is that we cannot invent AI in our own offices and labs. So most of the AI development that we are doing at the clinician side. Our clinical scientists work with the clinical team, with our technology developers, and we try to develop an AI which empowers people, which adapts to the context. If it's developed for India, it should work for Indian population. And it integrates into the workflow. It should not become one additional thing which clinician has to take care of. I'll just give few examples of so that you understand what I am saying, how it works in the practical. We know that in MRI, image quality and time, these are trade-off, right? If you want a better image quality, you have to scan for longer time. But with the smart speed, now you can have 3 times faster imaging and 80% sharpness at the same time. So what this AI is doing is to reduce the trade-off so that you have faster imaging, that means higher throughput, more patient comfort and compliance, but when you have 80% higher sharpness, you have better clinical decision making also. Similar thing if we see in CT scanner, and that's true for MR as well, right? When we talk about AI, it's not a particular clinical feature, but how you integrate in the complete workflow, whether it's 3D camera-based patient positioning, whether it's scan planning, image acquisition, image reconstruction, post-processing. In everywhere, what you are seeing here is of course our precise platform, but in MR as well or any other modality, you will see that AI is working throughout the workflow to not only make the things faster or have better image quality, lower radiation, lower contrast, but also reduce variability. It's like if a doctor in this hospital is doing a scan and some other doctor in the other institute, can it be somewhat similar? Of course, human expertise will matter, but how we can augment that so that the variability reduces. That's what the AI is trying to do by being embedded in the workflow. When we talk about our advanced visualization workstation, right, because eventually from MR and CT, the radiologist is using the workstation. Then we have analytical tools which ensure that the routine things, whether it's a quantification, contouring, all those things system will automatically take care of. So those repeat tasks gets reduced. You have more consistent data because you are less human dependent. And then you have an intelligence built which is helping clinicians in the clinical decision support. So that comes from our advanced visualization solution. Then what we talk about radiology, right? Whether it's increased volume, whether increased complexity, that's true for pathology as well. There also you have more and more complex cancer cases. But there is one more challenge. While you can apply AI on a digital MRI and CT data, you can't apply AI on a slide. So first you need to digitize those slides. So our digital pathology solution helps you digitize the slide. so that you can collaborate better and you can also apply intelligence which helps you in a better detection, better grading. So we have digital in radiology, we have a digital pathology also now. Then we have a cardiovascular informatics solution, right? Any cardiac patient has to go through multiple tests, whether ECG, echo, cath lab, MRI, CT. Now using this cardiovascular workspace, you are bringing everything together. So idea is that you are not spending time in searching for data, but you are spending time searching for the clinical answers. So how we are allowing you to move from data to answer, that's what the AI is doing. Then many things you can't do alone. In fact, we have worked with Nicolab, who is our partner, to bring this stroke viewer. You know that time is brain. So what we are doing, we can work for spoke and hub model where you are doing a CT scan, data is sent to the cloud, and the analyzed data is sent to the hub where the treatment will happen. So in the real time data is available with the care team while the CT scan is completed. So this we have worked with Nicolab. So these were few examples, right? The idea is not to present the comprehensive AI solution for Philips, but to tell that we all know that AI has a healthcare impact. It can save lives, but it can save lives if it is trusted by the patient, trusted by the clinicians. In our healthcare survey, we found that both clinicians and the patient feel that it will have impact, but there is a 20% optimization gap, right? While 80% of the clinicians feel the AI is good for clinical practice, only 60% of patients feel that. So that means there is a 20% gap, and that gap becomes more when it comes to clinical. More and more patients are comfortable AI getting used for the scheduling, for the check-in purpose, but when it comes to clinical decision support, they have apprehension because of course, they want to spend more and more face time with the doctors. So how we fix this trust will make sure we scale up the AI. Otherwise, it will remain in the hands of the few expert early adopter. If we want to scale up the AI, we have to ensure that as a vendor, I am saying more from the vendor. So as a vendor, we do the development with the clinicians in the field. So all the stakeholders are involved from the beginning and throughout the cycle. While AI will augment and empower the clinicians, we also need to ensure that is always under the human supervision. We are seeing AI becoming more and more autonomous, but in healthcare, always human supervision will be required. Then we are also trying to see that if we are building AI for India, it should be trained on the Indian population data, right? So there is no bias. It should work for the population for which we are deploying it. While we need speed of innovation, we need guardrails of safety, we need guardrails of regulation. And then at the end, we need a ecosystem, right? Where the payer, the patient group, the medtech company, regulator, they all have to come together to build a ecosystem where there are guardrails, there are enablers which help you sustain and scale the AI. At the end, I'll end by saying that while we are saying that AI will augment and enhance the skill of clinician, of course, human expert will always be needed. Final accountability, responsibility of decision making remains with clinician. They can accept the data, they can modify data that they are getting from the tool, but eventually they are in charge and the AI is an assistant to them which is helping them do more, which is helping them to consistently deliver better quality imaging to every patient irrespective of where they are treated. As I said that we are trying to achieve better care for more people without any variability. So it's not AI which will impact the healthcare, but it's the AI plus clinician working together will bring the change. Thank you.
Thank you for your excellent talk, sir. It is my pleasure to welcome someone who believes in technology when it improves lives of people. Please welcome Dr. Roshan Christina for her talk on intricacies of AI tech.
Good afternoon, everyone. I'm Dr. Roshan Christina. I'd like to thank the organizers for having me on as a speaker today. I'd also really love to have more of an audience, and if the organizers could help with that, I would really appreciate it. So this is my topic for today, and as clinical consultant in AI ophthalmology and oculomics, I will be talking about this from that perspective. And I'd like to start with a confession. Over the years, as an ophthalmologist, when a patient sat in front of me, I saw the eyes, thought about the eyes. That was my job. If the patient had high blood pressure, that was someone else's problem down the corridor. But now, every time I see a patient, I realize there's more to it than meets the eye. Here's how. The retina, the thin layer at the back of your eye, develops from the very same tissue as the brain. It isn't just the organ for seeing the world. It's the only place in the human body where live blood vessels and neural tissue can be seen directly. No cutting, no contrast, no radiation. These tiny vessels in the retina carry signals about your brain, your kidneys, and especially your heart, years before the patient can even feel a single symptom. Think of it as a car dashboard. You don't really need to open up the engine to know something's wrong. Just one warning light tells you. And your eyes work the same way for your body. The warning signs of a failing kidney, a struggling brain, a stroke, or a heart attack waiting to happen can now be written in your eyes long before it's written in your medical chart. For years, doctors have been looking through this keyhole, but what we haven't had until now is the power to fully read it. The foundational moment came in 2018 when researchers gave an AI thousands of retinal images with no instructions and realized that with deep learning, it could not only predict the cardiovascular risk and the blood pressure, but also predict the gender and the age as well. Now, all of us qualified ophthalmologists know that our very own trained eyes, for all our expertise, can't see gender in the retina, but AI could. And this led to the birth of a field we call oculomics, the eye as a window into the whole body. Now imagine giving that window to a machine that never blinks, never tires, and can scan 1,000 images before lunch. That's what AI, and specifically vision language models, now lets us do. They don't just detect a lesion, they describe it, they reason about it, and write it up in a language clinicians can act on. Now, this is no longer confined to a research lab. When a patient walks in for a routine eye test, a retinal scan taken in minutes can be analyzed by AI to estimate cardiovascular risk, including the systolic blood pressure, cholesterol, HbA1c, and biological heart age, all in seconds. That's not science fiction. That's happening right now in models like the one built by Forest Health right here. FH Poise, Forest Health's AI algorithms, now includes CVD AI, a case study in how to do this responsibly. Most retinal AI tools output an opaque risk score, say a black box that even doctors can't interpret. But this one is built differently. From a single fundus photo, the system reliably estimates systolic blood pressure, cholesterol, heart age, and glycemic control by means of HbA1c levels, all from retinal features alone. The model has a performance matching, let's say even exceeding, prior published methods. It estimates important biomarkers that physicians already know how to act on and feeds them into the ASCVD and Framingham risk scores, which are the very same guideline-based models that cardiologists already trust. The model then reports the risk from both scores and defaults to whichever is more conservative, so no patient ever gets understratified. Now, the differentiator about Forest CVD AI is that every image is automatically checked for quality before scoring. So a poor photo triggers a retake request rather than a silent, unreliable prediction. The model also runs on a standard clinic hardware, so no GPU cluster, no cloud dependency, all delivering a result at the bedside within seconds. It's trained and validated on UK Biobank data from over 20,000 participants, with validation on Indian cohorts now underway. And it isn't only the heart. Preeclampsia and pregnancy, diabetes, kidney disease, Alzheimer's have all been found to leave footprints in the retina long before you see it anywhere else in the body. Now, I understand if this makes a few clinicians in the room feel uneasy. Sounds like AI doing your job. I felt that same discomfort myself. So let me say this plainly. This right here is pattern recognition, not diagnosis. A model can say that this retina shows elevated cardiovascular risk, but it can't really counsel a frightened patient or weigh that risk against their entire family history. That remains squarely our job. But here's the real risk. Not AI replacing clinicians, but AI being built without us, without that clinical grounding. And if we don't engage, the future is going to be built anyway. The question being whether it's built well. Let me bring this to life with an example. Say a 65-year-old man walks into a rural clinic for a routine diabetic eye screening. No chest pain, no family history. BP looks borderline normal. The fundus camera takes one image, the AI reads it in seconds, and flags something unexpected. A heart age of 72, along with elevated cardiovascular risk markers from his retinal vasculature. Here's the critical part. The model might be technically right about the heart age, but it can't diagnose him with heart disease. It only raises a flag. That flag goes to the clinician, the human in the loop, who reviews it, correlates it with the patient's full history, and refers him for a cardiology workup where, let's say, early arterial stiffening is confirmed. But all this years before a heart attack would have said the same story. That's not AI replacing the clinician. It's widening the clinician's field of vision and the doctor closing the loop with judgment the model doesn't have. So AI gave us speed and scale, and the human gave us judgment and context. Neither alone would have caught it. That's the real unification we need. It's a closed loop. The model infers, clinician verifies and corrects, and that correction feeds back to make the model sharper next time. Human in the loop is the engine that makes the AI trustworthy to scale in the first place. So why does this matter to everyone in the room? To the clinicians, this isn't a threat to your expertise, it's leverage for it. It's a new non-invasive layer of risk detection that brings specialist-level insight. It gives your patients something concrete to see, and seeing is believing, so it's definitely going to improve the way they follow through on treatment. An eye exam doubling as a cardiovascular screen gives ophthalmology a place along cardiology, possibly other specialties, not competing with them, but complementing them with a uniquely accessible diagnostic window. Remember, a model's output is a lead, not a verdict. You're still the one who decides what happens next. To the technologists, this is a case study in what's possible when medical imaging data meets deep learning. Also a reminder that impact in healthcare AI comes from enabling the clinician. Build models that explain themselves and flag uncertainty, because a model that can't be questioned by a clinician is a model that's less likely to ever get deployed. To the business leaders, this is a market signal. Affordable, scalable, and non-invasive screening that can reach underserved rural populations where expensive imaging infrastructure is less likely to exist, while also easing the burden in overstretched specialist clinics in urban areas. Human in the loop isn't friction slowing down your deployment, simply because trust is not a soft metric. It's your adoption curve. It's what makes deployment possible at scale without regulators or clinicians hesitating to say yes. Lastly, this field deserves honesty. These technologies are still working through regulatory approval. Underlying data needs continued independent validation across diverse populations. But the direction is undeniable. We are watching medicine move away from siloed specialties towards a more whole, connected understanding of the whole person. And that shift is being led through the eyes. Imagine, in clinics, even optical stores, this technology can catch silent threats like heart disease, diabetes, stroke in people who walked in for nothing more than a new pair of glasses. Leading this transformation is Forest Health's FH Poise CVD AI. One retinal photo revealing cardiovascular risk and glycemic control instantly. So the next time you look someone in the eyes, remember you're looking at a living map of their health. And for the first time in history, we finally have the power to read it. The technology is real. The science is here. The question isn't whether oculomics will change healthcare, it's how thoughtfully and how quickly we choose to embrace it. Let's be the ones holding the lens. Thank you.
Any questions? Thank you, ma'am, for an insightful session. AI has the potential to make the pathway smarter, faster, and more personalized. But achieving this requires more than technology. It requires trust, governance, and clinical leadership. Let's move on to our first panel discussion on AI and its impact on clinical pathways, moderated by Ms. Kalavati GV, and our panelists are Dr. Arjun Kalyanpur, Dr. Supriya Semanapalli, Dr. Sudhir Kumar, Dr. Vimal Raj. Please join on stage.
Good afternoon, everyone. I think you can hear me very well now. Yeah, it's working. So thanks for this great opportunity. I'm extremely happy to be part of moderating this session with some of the very well-known and inspirational people across India, I would say, and also global. So with that, what are we speaking about today? If you look at the patient care journey, imaging is often one of the most earliest and an important touch point. It supports the clinician with making the right decisions, from diagnosis, the treatment planning, and also to monitor the disease progression. Today, we will explore how AI can further transform the imaging-led care in India. India, yes, it's extremely important, right? By improving quality, accelerating decision, and making advanced imaging much more accessible, which is key. So with that, I will ask the first question to Dr. Sudhir. I wouldn't go in the same order what we are sitting, so no, it's fine. So we often discuss AI in the context of image analysis and then reporting. Now, shifting to the earlier part of image acquisition, let us say if we apply AI there, is it going to help bridge some of the knowledge gaps that we have with the workers and help us to extract more value from the images?
Yeah, perfect. So before I get into that question, let me just set the context. So usual clinical pathway has been something like a patient is there, clinician is there, radiologist is there. Now over the last decade and a half, this AI has been coming into the picture and has been making steady progress and getting itself into this pathway. And so here with the AI, we can look into it like AI plus clinician and AI plus radiologist. So you can have these as the two pathways. And the AI plus clinician in the sense that one is the clinical parameters, lab findings, and then also with the kind of risk factors, what are the available investigations, they can help to a greater extent in actually optimizing the right investigation for the patient. Right. Now we'll come to your question when the patient enters the radiology. So when the patient enters the radiology, definitely at the point where we have to protocol it. So with the advent of, with the AI getting integrated into the workflow, So it is helping us in improving the quality of images, improving the reconstruction algorithms, and also simultaneously it is helping in dose reduction. And also, most importantly, I think we have critical alerts which are coming. I think there are so many, like picking up hemorrhages in the workflow, right? And all this coming together has really enhanced the part of the patient where the patient needs to get scanned. And so it is helping us optimize. Then when it comes to the radiologist part, radiologists try to see these cases with the help of AI. I mean, they are able to detect the lesions better. Now there is some kind of quantification, like about the lesion detection, and coming to about the quantifying it, then standardizing the reporting, as well as structured reporting, because the reports from radiologist to radiologist vary. So AI is helping in getting a standardized reporting and also a set of data which will be available for research. So all this put together is definitely enhancing, and also the report is much more readable in terms of the clinicians when it goes to clinicians. So the multidisciplinary team meetings are much more robust now with this kind of information. So all put together, if you look like, I mean, to just sum up, it will be like now AI plus clinician plus radiology, which is equal to patient benefit. So that is how
I really
like
liked your equation. I think you explained it so well that using AI, it is going to help the clinician and all the care providers in the pathway to really focus on the patients much more and make it much more standardized. Thank you very much. Thank you very much. Now, Dr. Vimal Raj. Okay, I have known Vimal for a very, very long time, and then he has served in multiple countries. And here is where I will ask him about the context of personalized and predictive care. Now, clinicians have a lot of access to non-imaging and imaging data. How is AI helping translate this information into better clinical decisions, and how will it enable stronger collaboration across the departments in the future? By the way, I would ask you to leverage your experiences out of India and then see how can you apply that through this journey.
I think a lot of talk is on personalized medicine. We all talk in terms of looking at every individual case and making it personalized to the care that people are given. And multidisciplinary teamwork is also very important that we need to look at. I'll give you a couple of examples, real-life examples, not something which is yet done in India, but something which when we were working in Cambridge, we used to have a specific MDT which looked at adrenal glands. So for people who do not know what this is, that adrenal gland is an organ which is less than 2 centimeters to 3 centimeters, and a lot of body's cancer goes there. And if the cancer goes there, the treatment changes. But that adrenal gland can also have benign pathologies, which is not cancer. And we used to have this MDT meeting. We had a surgeon, oncologist, radiologist, everybody coming and saying, lung cancer, which is known, is this adrenal lesion an abnormal lesion? Is this cancer or not? You would imagine imaging would help. The answer was we would spend hours together and we would not know. And then there was one brave surgeon in our unit who would go and biopsy these or operate on these. 7 years later, I go back to the same institute. I go and sit in that MDT. We have only 2 people in the MDT, where we used to have 7 or 8 clinicians sitting together. And this is the MDT coordinator, this is the oncologist and the radiologist. And they say the same case, and they say, this doesn't need biopsy, this doesn't need biopsy, this is benign. I was like, how did you make that decision? What's happened in 7 years? And AI has happened in 7 years, where They looked at all the data that they had over the last 20, 30 years, put it together into the AI model. The AI model's prediction of whether that lesion is going to be benign or malignant was better than their histopathological output over the last 20 years. So they realized that the clinical pathways that they had were not strong enough. So the multidisciplinary team, which we talk about improving the multidisciplinary team work, I think that multidisciplinary team will exist not in front, it'll exist in the back. Everybody will have access of every data. The other example I would give is we were working on a cardiac solution for a US company where in the left atrium of the heart, there is a small appendage which can lead to stroke. So we close that appendage. So we were trying to annotate some data to help them in developing models to block that. And we found a small diverticulum, like an outpouching from the LA in about few patients. So the person who was annotating it said, "Doc, is this something important?" You know, olden days, we would have called up cardiologists. Have you seen something like this? What happens? Cardiac surgeon, maybe a pathologist who does post-mortem to turn around and say that. Today, we have a model which basically looked at all our data, turned around and said, hey, in the 80,000 cases that we have imaged in the last 1.5 years, it's available in this many patients. These many patients end up having stroke, while these many patients end up having a cardiac arrest. So data and AI analysis is actually bridging the gap between multidisciplinary team working. It is making personalized. So I could tell that patient, hey, I've seen this problem, and previously I would have said, I don't know, maybe 4%, but I'm able to say, based on our data, this is your risk. So that personalized care with AI, with data, is actually going to a very different level. And multidisciplinary team is going to become much more easier, and often you may not need a multidisciplinary team because the AI will probably tell you what is the outcome expected.
Thank you. Thank you very much. That was wonderful, comparing how it was previously and how it is making the job of the clinician much more effective. And it is not about not having the multidisciplinary team, but their voices or focus can be used elsewhere, which is very much needed. Okay, thank you for throwing light on this. So Dr. Arjun, right, over to you. How can India improve access to advanced imaging? This is the technological side, especially beyond major urban centers. Given your background in teleradiology, how do you see remote acquisition and remote radiology working together to expand access and improve quality and support timely care across the country?
Thank you. That's a very interesting question. So I'd just like to clarify one thing, which is that our organization, while we report scans for hospitals in the US, there is also a practice within India. And as part of that practice, one of the things that we do and we have done is work with very remote parts of the country, like the state of Tripura, for example, where for a period of 3 years, we delivered remote reporting of teleradiology services. And this was not advanced imaging, this was just X-rays. But the state was so short of radiologists that they didn't have the wherewithal. So we set up a network infrastructure to capture the images from community health centers, district hospitals. Some of these were not even digital. We had to figure out a way to digitize them. Bring the images into a JPEG format, from JPEG format to DICOM, and then transport them to our server and then have them reported through our panel. So that was for us the entry point for this kind of access issue into rural India. Following up to that, we did a project where we partnered with an NGO, and now this brings us to your question, where they they ran a mobile service doing mammography screening in rural areas. And while the project was successful, and we even coupled the teleradiology input from the mobile van with AI, what we realized is that if you're going to go to this extent of doing mobile van teleradiology, you should get more bang for your buck. So today we are pioneering or piloting a project where we are putting multiple pieces of equipment on a single van, including digital X-ray and mammography. We're also doing things like oral cancer screening and HPV, cervical cancer screening. But fundamentally, the goal is on a single mobile unit, you can do multiple screening tests and using teleradiology, bring the images to a central reporting facility. And this can be used for TB as well as breast cancer. So I think the combination of mobile with teleradiology is very powerful. When you add AI into the mix, it's even more so because in the screening environment, you're taking some of the burden off radiologists by providing them an assisted read, or in an environment where there is not even a clinician, you can at least, I was talking to yesterday a radiologist in Jharkhand who has set up a similar network in the state. And he said for TB screening, when the report goes out, there's no doctor to counsel the patient. So it's direct radiologist to patient communication to ensure that follow-up is done for the patient screened for TB. So I think this combination of teleradiology and AI allows us to reach out directly to patients in rural India and really impact patient care and raise the bar.
Thank you. That is so enriching and then very good insight. I think in your previous talk, you spoke about emergency medicine. So what is the impact of AI in the emergency medicine from your perspective?
Well, that's where the impact is actually most profound, because what it does is really shave seconds, minutes and seconds off the turnaround time for reports. And at multiple levels, it adds value. It allows us to acquire images from a very distant location where the radiologist is not available and report within, for example, we can report a stroke study done in Boston or New York within 15 minutes by one of our radiologists here in India. So it has completely changed the game in terms of instant reporting. AI has shortened that time down even further because that 15 minutes now comes down to 1 minute. So the leaps and bounds with which technology is impacting emergency care is really staggering. And I think stroke is probably the best example.
Absolutely, absolutely. The golden time is extremely important, and then you touched upon a very good point. Thank you very much. So over to you, Supriya. From a technology standpoint, is India ready to handle the healthcare data at scale and move meaningfully towards preventive and then predictive medicine in this decade? That's important, in this decade. How can industry help build and strengthen this pillar to support this transition?
All right, before I begin, I'm very privileged and I feel overwhelmed to sit alongside this eminent panel. Thanks to the organizers for this opportunity. Yeah, and it's a quite loaded question, Kala. There are three aspects to it, right? Much before going into the technology aspect, I think we should shortly discuss about the scale of the problem, right? And in the context of India, as you are questioning, we are talking about a nation which is hosting 1.4 or 5 billion, right? Millions of patient interactions. And the data we are talking about is in probably terabytes, and terabytes is a short term, but it's about petabytes or zettabytes that we are talking about, where there are imaging studies thrown off, discharge summaries, we have pathology reports all thrown. And the day in, day out churn is something amazing. And it is this particular volume which is needed to be meaningful in order to make an impact. And now that's the scale of the problem we are talking about. Now comes the interesting part, right? Which is healthcare doesn't have any problem with the data, right? I say it boldly because I do see a lot of data day in, day out. Healthcare doesn't have a problem with data. The problem comes with understanding of this data. And why is it a problem? It's because, like we all know, more than 80% of the data is actually unstructured, right? Be it your radiology reports, clinical notes, or the PDFs, or any pathology reports which are present or embedded in your PDFs and stuff. It is all unstructured. So the need of the hour is definitely bringing a structure to this to make a value of it. And that's exactly where we would have to probably, before even talking about predictive medicine, we should probably talk about connected medicine. And yes, organizations like ours, where I come from, Siemens Healthineers, have built-in connected ecosystems where we have state-of-the-art platforms from Singo and digital healthcare platform, wherein we bring in imaging, operational, and clinical flow together in a connected way. And what happens with this power when things are more connected is that we break the silos. And the moment we break the silos, it becomes easier for AI to leverage that radiologist to probably identify the emergency patients much earlier, identify the disease patterns much before the disease actually manifests, and thereby getting into the preventive mode, right? And here we are not talking about improving efficiency. We are actually talking about improving access to healthcare at a population scale. And that is the need of hour for India.
Thank you. That was very well summarized. So now I would like to ask one question to all of you, right? Until now we talked about how AI can improve the efficiency, how it can impact in the multidisciplinary setting, and then how can we make the data collaborate much more across departments, etc. Now, when we talk about AI and then scaling, which Supriya, you touched upon, what are the barriers for the AI adoption today, okay, apart from the cost? I think it requires some mindset change, okay, and a greater confidence that can lead to broader adoption. So I would like to ask each one of you, what are your thought process with this, I would say, the challenge that we are facing?
Can we do a short exercise, also involve the audience here with that question?
Absolutely. Yes, anybody wants to take this question?
So the question is, what are the barriers in AI, right? Maybe let's try to do a short exercise. I would request the audience to raise your hands if you have used any kind of AI tool till now, right? Be it ChatGPT, Gemini, Notebook, LM, anything or any sort of AI if you have used till date. I'm actually surprised there are very less hands. Let me also raise.
You may ask questions.
Yes,
so
okay. So let's please keep the hands raised. Yeah. Now my second question would be, how many of you have blindly taken the response to the core and probably executed it? There you have your answer, Kala. So you have your answer
Absolutely,
there.
absolutely. Thank you for that. But at the same time, I would like to get your perspectives, right, in your own domains, in your own enterprise. What do you see as a challenge, and then what are the things that you're doing?
Especially in the healthcare where we work, so it's mainly one is the privacy and data issue which comes into play.
Absolutely.
Lot of limitations when it comes to a proper corporate healthcare, sharing the data with an external vendor. That is one thing. And secondly, I mean, there is no much clarity about the regulatory as well as medico-legal aspects of using the AI and its interpretation, some pitfalls. I mean, all those things are still, I mean, there are few things in place, but still it's vague, not very much concrete. And apart from that, I think, yeah, I mean, especially like say for a radiology workflow, if it is easing the things, that is good. But if it is adding to the workflow, if it adds to the turnaround time, like especially correcting the AI things, if it is not a very well completed product, then it might add more time in select situations, I can tell. So these are 2 or 3 things which comes to my mind.
Thank you. Thank you.
I wear 2 hats. I am a founder who sells AI, and I am a clinician who buys AI. So I have 2 perspectives. The answer to your question was very simple, but you put a but in there in saying, why is AI adoption not that good except from cost? I think in an Indian context, the first reason is cost. The last reason will also be cost. And the reason in AI that in India that is true is because as of now, unfortunately, doctors, radiologists, and other physicians are cheaper in India compared
Absolutely.
to AI. It's something very sad, but that is the reality. If you go beyond that, the biggest problem I see is when you go and try and sell your AI, people are looking at the utopia of an AI solution which will do everything from the word go, which I don't think is realistic. We need to have clear understanding of what AI can do. So, for example, I get a fellow every year. The fellow who comes at the start doesn't know much. I train them. By about 3rd month, they are useful. By about 8th, 9th month, they are extremely good. So if an AI solution comes, I want the 9th month fellow without having put in the effort of that 3 months with that fellow, which I think will happen in future. But the user has to be realistic in understanding that it is not going to give you everything. You have to put in your effort. It will make your life easy. The last thing which I feel is integration of different solutions in your workplace is a major challenge. You know, if I am sitting in front of my PACS solution, my AI for cardiac is given by something else where I have to go to another platform. My AI for brain is given by another solution, which looks very different. I have to learn that. And then whatever I see there doesn't come to my report. And whatever output goes to the patient perhaps is not the same at all. So this integration is a big problem with some people are solving it, but still not to the level that we would like it to be.
Thank you. Thank you. Dr. Arjun, do you feel?
So as I see it, and in our practice, we're using AI algorithms continuously. There is an inertia, and there's a sort of we are creatures of habit, and we are used to doing things a certain way. So it's the same as with any other technology adoption. There's a learning curve, and there's a kind of a resistance to that learning curve in the earliest stages. With anyone, it's more steep at the when the age increases. The younger people tend to be more receptive to new technologies. But across the board, I think the biggest effort, the biggest mindset change comes with just repeated reminders, education, constant reinforcement of the value. And one thing I will say is that for, at least in our practice for a radiologist, if you've missed a finding and the AI has picked it up, that's a very powerful influencer, more than anything else. So we take those examples where AI has detected something which a radiologist has missed, and we use that to reinforce the value. And slowly we see people, becoming more and more receptive to adoption.
Thank you. Thank you very much. So Priya, apart from the audience poll, do you have anything to add?
All right. I think Dr. Vimal very rightly touched, right? It's about the connected ecosystem. And the bigger picture is, from a technology standpoint, how do we bring in these service providers, hospitals, policymakers together to get that right connected ecosystem, right? Because be it predictive medicine or any other thing, I don't think it's going to be solved by AI alone, but it's the connected ecosystem.
Yeah. Thank you very much. So if we have to summarize, it's going to make the job easy, but we have to be very clear about what we are expecting from AI And we have to reinforce that as a habit, right? Then it'll be much more effective. And we have to take care of the medico-legal and data privacy issues, which is extremely important. And all in all, we have to make it work for us. Okay, that is the direction, and cost remains the biggest barrier. We need to see how we can, work towards that and design our systems better. But AI is going to help us on early detection or in every aspect of the patient care. With this, are there any questions from the audience? Because this is a great opportunity to really understand from people who have been pioneers, I would say, have been sitting here. Don't miss the chance.
Yeah, one question. So we are in a country wherein there has always been dearth of hospitals and doctors along the way. With AI coming into the picture, are we finally seeing an era wherein healthcare becomes universal and accessible to everyone?
The simple answer to that question is yes. It will make it universally accessible. When and how it happens in India is the biggest question mark. And who will be driving it? See, one of the bigger problems in one way it's a problem, but in another way it's a greater opportunity, is that we are fragmented at every level of what we do. The providers are fragmented, the users are fragmented. There's no uniformity. AI will definitely enable universal access. It'll bring in significant leaps and bounds in way people are using our healthcare services. But how does it reach the ones who really need it or the ones who really deserve it is going to be a big question. You know, you keep seeing memes on Instagram and say, you go and urinate or pee in front of a tree and it'll tell you what your disease is. If ants are growing, this is happening and stuff like that. That is going to be a reality. This is what happens in China. I've been to one of those clinics where, it's a semi-public toilet which tells you, it gives you your report as soon as you're out of the room, what's happening with you. So it will happen. How and when is the only big question.
Let me be a skeptic. How is this going to affect the human brain development? You think this brain will become a vestigial appendix?
Well, I think that's a genuine concern. Actually papers have been written which show that the quality of trainees is diminished by the use of AI. So, it's a challenging era that we live in. We are dependent, or we need AI, but at the same time, we can't allow ourselves to be dependent on it. So I think it's more of an existentialist question about how we conduct ourselves and manage educational programs in the era of AI. I think we have to moderate its use very carefully, the way we've moderated social media use among teenagers. It's a similar analogy. Set rules as to when it's to be used, when it's not to be used. Force trainees to first use their minds and then use the AI as an adjunct rather than the other way around. So I think as long as we're careful about how we implement the use of AI, I think we should be okay. The terrible mistake would be to say that it's very risky and we shouldn't use it. We should not do that at any cost.
I would say from a generic perspective, there are multiple industrial revolutions which has happened. Every time, humans have found better way to augment with whatever has come in. So I trust in that. Absolutely.
I'll give you a very practical example. This happened about 3 years ago in our house. One of the many reasons why I fought with my wife. My wife insists on my daughters having a good handwriting, and I insist on them being faster in typing. And then we were having this argument, and my younger one comes and says, "You both are wrong. I just need voice to text. I don't need either of them." So this is going to happen. Which way it'll move into, really don't know.
So we have, from the morning, we keep talking through about like how accurate the decisions could be with the intervention of AI and the speed that we have talked through and how it will help the pathologist in looking into the accuracy of the images, right? So this is all at the operational side, helping the care providers, the hospitals. Now looking into the member side, though a lot of digitization, LLMs and the AI coming into the picture, still we see the member non-adherence to the treatment plans. They may not be ready, right? And at some point of time, they keep dropping off from the treatment, and that increases the healthcare cost and the spendings. So what do you think that we can do with the help of the AI? Is there anything that we can make out in the early signals where we can intervene at the right time and bring them into the adherence and the care continuity?
So the thing is, the AI is such a universal solution, and everybody will modify it to its own requirement and how people do. I'll give you a very powerful message that we see. For example, you go and get yourself a blood test done today, and your cholesterols are a little abnormal. Your doctor says you need to be on statins, you need to start medication. 90% of this room will say, give me 3 months, I will go exercise, live healthy, and I will not take medicine. 3 months down the line, the same results. Now, if you intervene and put a calcium score CT scan, which we are big into, and it shows that there is evidence that there is already damage to your heart, the adoption of medical advice is significantly better. So for the members or people who are in the pipeline, when they get to know the effect of what they are doing, because people will get, see, the challenge will be slightly different. People will be bombarded with information and people won't know what to do with that information. And I think people will be made more scared rather than what they need to be. So the answer is, the technology is already there where people are being told why they need to be in that therapy, why they need to stick to that regime, and there will be constant support for them, which will keep promoting them to come back and get their therapy done. So AI definitely will do that.
Yeah, so I have a question. So on one side, we talk about precision medicine, precision healthcare, individual treatment, individual medicine. At the same time, we talk about also connecting ecosystem. But how do you think AI is going to bridge the gap of diversity and inclusion in healthcare?
I'll just say one thing here. I mean, there is AI and there is AI. So I don't think that it's one all-encompassing solution there. But today in imaging, for example, you have, so the example I showed earlier, mammography screening for breast cancer, that will look at very large data sets of mammograms, which is essentially what is required, right? You need a kind of a global platform for screening for breast cancer. But at the same time, there is a different type of AI which adopts technologies such as radiomics and radiogenomics, which are hyper-personalized, where your genetic information is fused with your radiological data, and the diagnosis is extremely precise and personalized to the individual. So I think AI can simultaneously achieve both goals.
Okay, thank you.
Hi, there was one discussion on the barrier of adopting AI, and sir, you said that cost remains the first and the last barrier. Having said that, I mean, cost is a function of demand and supply. And in today, the healthcare cost is higher, and primarily in India, primarily because the supply is very stark compared to the demand we have. The way to look at AI is going to be an engine to create more accessibility. And we all know that diagnosis or non-diagnosis or late diagnosis is the critical factor in Indian healthcare rather than cost per se. So, and we, on the other side, we also know any technology evolution has only commoditized things and brought down the cost. So in my mind, the way I see this is AI adoption with less clinicians today is going to be a force multiplier and should bring down the overall healthcare cost rather than cost being a barrier to adopt AI. Your thoughts on this, please?
I totally agree with you. I think that's the only way it is going to go forward. The only problem is the entry-level barrier where people are not ready to accept that at a smaller scale. See, for example, we as an institution believe that let's just take an example I was discussing with Dr. Rawat earlier. Chest X-ray reporting, we have beautiful solutions from AI products. Now, we adopt that, we pay them X rupees, we still need the radiologist to sign that report, who also needs a Y rupee. So for an institution to adopt that, it is a force multiplier. I would report 10 times the X-rays that I would report currently. But I have already employed 10 people in my institution for that work. So if I start doing this right now, it will not. But the next time somebody leaves, I may not recruit somebody in place of them. So it will happen. I totally agree with you. How long will that take is the million-dollar question for India at least.
I don't know how we are doing on time. I see 1 minute. Yeah.
And everything. So my question is like, since we have a very ratio gap between the patient and a doctor, at a grassroots level, like starting with the screening, can we use more allied health forces, to take care of the screening part? Like, for example, I'm not sure, but I think recently they have started using ASHA workers to screen for oral cancer. So like that, can we extend the power of AI in, training the health allied forces to go out, in the villages or at the grassroots level, at least do the screening where they can get the cases for the doctors to review?
One experience, I mean, there is a active program currently, as you described, for using a smartphone to detect oral cancer with an app. And I think that's the way of the future, really, to have, the solution on a handheld device which can be used in the field to detect, for example, a skin lesion or, anything that is physically visible on the surface. Where I guess this panel has a challenge is because we deal with imaging, where you needed a piece of equipment to acquire the image in the first place. So the closest area which would apply to the example you gave would be ultrasound. Now today in India, unfortunately, there's a challenge, which is we have the PNDT Act because of female feticide. So we're not allowed to really use a lot of AI solutions for handheld ultrasound. In fact, handheld ultrasound doesn't really exist in India except for echocardiography. But the concept is very, very powerful. So I think what you propose of having handheld devices in the periphery doing and training,
even like
entry-level workers.
X-rays of the heart, they can be used like, at least looking at the lesions, like for example, lung cancer, everything. They can have the, the imaging doing at the grassroots level and collecting the data. Like, it also help in understanding the cohorts.
Yeah.
Like sometimes at the grassroots level, because of certain, environmental factor, these things comes in.
There are small handheld X-ray machines now as well. So that's another area which you'd be seeing in the future.
So if I could just add on to what Arjun had said about their experience in Tripura. So our startup is basically working in Nagaland. Now in UP, we have healthcare providers who are on a bike, who take an X-ray machine on their backpack. They go and take a chest X-ray as part of TB eradication. They take a chest X-ray on the spot. AI detects it and says possible TB. That healthcare provider now has to wear 3 hats. They suddenly have to start taking the sputum sample at the same time. They become a dietitian with a proper clear of saying this is what you need to do. They also become a part of a pharmacy where they say this is this till the chest X-ray gets reported by then. So the role of allied health is expanding, but there will be limitations based on regulations, but otherwise the role is expanding, and I think AI is definitely helping with that.
Thank you. Thank you very much, and thanks for the very interactive session. Thanks to all the panelists. Yeah.
As we know, technology has the power to make healthcare accessible to all parts of India. Moving on to our next panel discussion, Beyond the Hospital Walls, Building India's Distributed Care Infrastructure with AI. This discussion is moderated by Dr. Vijay Raghavan, and the panelists are Dr. Charit Bhograj, Mr. Dikshant Dev, Mr. Satish Kumar, Dr. Chandrika Kambam, Dr. Reema Nadik. I welcome them all on stage.
Thanks a lot. I think our stage is set because of Ritu. Actually, that's the question we want to answer. So if there are people in this room who are still figuring out what's the next that's going to come and how may we repurpose a lot of building blocks that we are building for the future, then this is exactly the panel. Okay? Few rules. One, I've had a lot of conversations with them. They are real people. They've gone through real challenges, highs and lows, more money, no money, more pain, no pain, high number of Jira tickets, all of these in life. So they are people who are real people who have done it. So I was requesting them that as much as possible, we speak the truth. Second, as much as possible, we speak the mistakes we've done so that we don't really revisit the whole. It's going to be an interesting 60 minutes. We're going to talk beyond the hospital walls. So if you're from hospitals and you're tired, then this is the right panel to be in. If you've been frustrated with what you've gone through in life because your hospital was not close by, then this is the panel you got to be in. My job is to moderate, to get the best out of them. A lot of questions that I've packed in is all coming from you. So it starts from there. So I hope you relate to the questions as we go. Okay? Let's quickly start with something which is real. No fake, something very real. How many people in this room have visited a hospital which was 50 kilometers away to admit someone? Or how many people in this room know of someone who had to travel a long way to admit a patient? Yeah, 1, 2. How many people how many people in this room have heard of people driving for several hours to get a basic diagnosis done? Yeah. Keep the thought alive. There are more people than you actually think. The real fact, I'm going to put it bluntly, last year we set up or added 40,000 beds. That's all. What we need to serve India, based on even World Health Organization standards, if I were to put the number, it's 2.5 million. To get to base level of 2.5 million, we will take 60 years. So I'm going to ask you this question. How many of you think hospitals are the only future? Please raise your hands. Beautiful. And how many of you think there is something beyond hospital that's going to brew over the next few years? Great. Thank you. It's easy for me to do this job from now on because you already know what I'm trying to say. Okay. I'm going to give some time for each of my, just 30 seconds to introduce each one of them. They're all here with a purpose. Do not look at the company they come from, the product they built, the journey they've been through, but look at the lens they're going to bring. That's the point I want to always look at. Let's get started from you.
My name is Dikshant, and I'm the founder and CEO of Zigment. At Zigment, we basically provide an AI-powered or agentic AI-powered patient journeys. And with patient journey, I mean taking care of all the engagement that happens between the institution and patients in their journey towards a better health. Somebody in the previous panel mentioned about how disparate the systems are in a typical organization. We basically, our platform tries to solve that problem, like by integrating everything together.
Hello everyone, I'm Dr. Chandrika. I'm the Medical Director for Even Healthcare. We are trying to build a new age healthcare delivery system. We call it as Pay Wider model. We'll discuss more during the panel session. And thank you GHA for inviting me here today. And pleasure to be with all of you. And HCG is my home. I've been groomed by the people, leaders of HCG. So it's like homecoming for me. Thank you.
By the end of this year,
3 million people will die due to heart disease, making this India's #1 killer. More people are pushed below the poverty line due to cardiovascular disease than all other diseases combined together. Hello, my name is Dr. Charit. I'm a cardiologist and the founder of TriCog. And my goal is to identify every heart patient, irrespective of where they are or whether they can afford it or not, and then get them to treatment. Today, TriCog has grown to be the largest cardiovascular AI company in the world. We serve 15,000 hospitals across 14 countries. And in India alone, we serve 1 million patients every month. 5% of India's heart patients are diagnosed by this little company in Bangalore. And our goal is to reach 100 million people by 2030. Thank you.
Good evening, everyone. I'm Dr. Reema Nalig. I'm the founder and director for a company called LifeBridge Group. And this is a company which deals with everybody what we are all going to become, seniors. So we cover the whole ecosystem of seniors, starting from healthy aging, lifestyle of seniors, to their health, which is not inside the hospital but outside, because we see that large requirement of healthcare for senior group it lies outside the hospital. It could be prevention, wellness, rehabilitation, palliative, chronic care, etc. is managed outside. So that's what we manage. And we also have a health tech, age tech platform which helps in aiding healthy aging. So we have created a whole ecosystem which takes care of seniors from the time they turn 60 to the time they are around on this earth. So that's what we are. We take care of around 3,000 active aging elders. We have around 650 beds in the care, and a large number of people who are using our age tech platform to keep themselves healthy, and the kids are able to keep their eyes from wherever they are in the world to see that the parents are doing well. So that's how we. Thank you so much for having us today.
Hello, everyone. Good evening. My name is Satish. I head the global research and development for MRI scanner in Philips. I have to say for myself, very, very passionate engineer. I've been developing MR scanner now for the last 27 years throughout my career. And we were discussing some time back what is my, the challenges. Two biggest challenges that I am also behind, making MR more accessible to more patients in the world, and also more affordable. And these are my two important goals that I have been behind for the last 26 years now.
Awesome. I think that's the only moment of time I was nice at them, letting them speak what they want to speak. After that, it's all controlled with the cards. Okay. Charit, since you did a great TED start, I'm going to put you on the spot. Very painful question. But the stat I have is even more painful. We catch heart attack 10 years before anybody in the world catches. 10 years before, an average Indian. And diagnosis happens much later. Patients is on the way traveling. So the question is, how is it that, a situation where disease arrives early and diagnosis happens late, and we have 20 years of telemedicine and nothing could save lives. What's grossly gone wrong in the way we approach cardiology?
Thanks, Vijay, and you're a dangerous moderator to have. I'll start off with that. So here's the fundamental challenge. The number of cardiologists that are there are about 6,500 people in India. And all of us are in big hospitals and big cities. That is far away from where patients are today. On the other hand, it took me 12 years of training to become a cardiologist. So you can't produce more of us fast enough. The flip side of this is the fact that the number of diabetics, hypertensives are only increasing, and of course, people who smoke and other lifestyle-related problems. So you have a divergent curve where the number of doctors needed is very flat. The panelists were speaking about it in the last panel. But the number of patients are exponentially increasing. This is a recipe for disaster. And to make this worse, this problem is only going to increase beyond 2050. So the WHO's projections is that cardiovascular disease may start tapering after 2050. And now till then, we have a perfect storm where younger people are getting cardiovascular disease. In fact, we run the government programs for heart disease detection across 7 states, Karnataka included. 18% of all heart attacks are below the age of 45. So we are setting ourselves for a time where in my generation, wearing glasses and perhaps cataract surgery and prostate surgery were part of growing older. But the generation that is coming, getting a stent may be another one that is added. So a perfect storm of lifestyle changes, population changes, and the fact that despite all efforts from the government and the private side, this gap is only going to worsen. And on the other hand, you pointed out that the healthcare infrastructure is just not equipped to deal with not just the acute conditions, which is what it's been designed and set up for, but to manage chronic conditions. So if you ask a doctor how much time you spend in prevention versus treatment, right, per dollar, the maximum impact you will get in prevention. Right? But in treatment, that's where all of us are still focused on. So a perfect storm brewing in India, which is going to have a significant effect, not just on the economy, but on families and healthcare systems at large.
It's a serious 25 years for us then. Okay, now back to you folks, some interesting question here. How many of you, be honest and, be unfiltered, honest and true to yourself, right? How many of you get excited hearing about the next patient app that got into the App Store and downloaded and just to delete it in 3 days? How many of you downloaded those apps and deleted in 3 days? How many of you frequently download apps and don't use them? Yeah. This is a serious problem, right? We spend tons of rupees, millions of rupees in building an app just to promote it and then put it on an app store. And then you realize the engagement also has to be bought. What's wrong? Why are people not using these? Why are we not? There are so many apps given by so many of us, right? Here's a question, serious questions for you, Dikshant, that, you build agentic workflows, you have patient engagement workflows which run digital, right? If I am a doctor, which I am, and I meet a patient, I always feel good and they always feel good. Both of us feel good, right? But that's not going to happen as we go, because about 4.5 billion people in the world don't have access to primary health systems at all. So we're talking about those who don't have access, and yet they need a great engagement. How do you build, keeping that future in mind where humans are not going to be there, and yet the experience has to be that amazing?
Yeah, thanks for that question and, probing it was good to see people kind of, voting down on app side. So we've seen that, back in the day when there were physical surfaces, like, you had to go to a facility and your data was stored in records and, files, etc. From there, we got into the websites and apps. They are still walls, right? They're like, earlier there were physical walls, now they are digital walls. From there, as we have come into now conversational era, things have started changing. Suddenly, you kind of, made the literacy required to engage and get access to, whatever you require in healthcare, suddenly starts becoming easier. So from our side, what we are seeing is that moment these walls come down, the engagement kind of increases immensely. And, that's something that kind of, you suddenly provided access to a much larger audience, that could be sitting out there in a remote village or anywhere in the world. Now, coming to the question of how, how to kind of make sure that these interactions are as humane as possible, as, because we just do not have enough medical kind of, people skilled in medical kind of operations. So only way for us to kind of is use AI in kind of, meaningfully and, in sense that we are deploying it well. But when it's done right, we are seeing that the AI is that force multiplier, as somebody had said, truly delivering that experience and primarily that access that's kind of has been, otherwise misses out with other modes.
Interesting. I still find the audience a bit controlled. You've been nice and decent and polite and kind. Let's increase the gravity of the problem, right? They're not here for the role that they play. They're here for the future they're going to build along with us, right? So let's put them a bit more on a stressful state. Okay. Insurance exists. How many of you say yes? Raise your hand. Insurance plan. How many of you? Please raise. Okay. Beautiful. How many of you have annual maintenance contract signed? Annual maintenance contract for your health? Annual maintenance contract for your health? Zero. I mean, I'm asking a simple question. We all go through it. I'm going through it live. I just had to admit my father-in-law in a hospital. I think when we fall on a bed, insurance works. Agree? Pre-authorization to authorization and everything is in system. But when we are standing and walking and running, there is no protection, right? Why is it? Is it because we never thought about prevention in equal respect? Or something is grossly wrong? Maybe somebody like you, who's a doctor, got frustrated, went into solving a problem, could give us some clues. So we would like to hear your thoughts on why is this protection not working?
Thank you for that question, and I think that is why I moved out of corporate hospitals and joined Even Healthcare, where we are trying to do something different. I'm going to give you a lot of some of our experience, probably which you don't have seen in the traditional hospital model. The primary problem with insurance and the hospital today is the fee-for-service model. Right? The fee-for-service model that we all execute day in and day out in our hospital system, how does it work? It is working to fill the beds. It is working to do more investigations. It is working towards to take care of the sick and not to take care of the health. And how does the insurance work? The insurance is also working to pay the episode of the sick care and not focusing on the health of the person. So that is the fundamental problem that we have in the ecosystem today. And how do we fix it? So somebody has to come forward and say that, okay, let's look at this, re-look at the way the healthcare is delivered in India, and how do we change this? There are lots of models that are already tried and tested in many countries. But we have to also see how we can adopt that to us. We have to move away from sickness to wellness. That is very important. And we also have to move away from the fee-for-service model to, say, capitation model. And we need to see how to give value to both the patient, the payer, and the provider in this whole ecosystem so that everybody benefits. So what is payer worried about? They are worried about the cost of care. So where is that cost of care coming? Because of the sickness, right? So how, as a person, like patients themselves, can also be involved in preventive care rather than sickness care? And how a hospital, rather than looking at the occupancy or doing more tests, are rewarded for preventing hospitalization? That's the type of questions that we are asking at Even, and trying to see how we can solve this problem by bringing a lot of things, into this equalizing the ecosystem and addressing each one of them and supporting the entire ecosystem to achieve this. The hospital should be a part of in the journey of healthcare and not a destination. And we need to bring in a value-based care system. In our hospital or in our organization, I'll always tell people that the value is derivative of two factors, that is cost of care and the clinical outcomes, which we are currently not looking at all. So most of the insurance is focused on sickness. Hospital is focused on taking care of sickness. And that's where the fundamental problem is. And that is why you see that 55 million people are still go bankrupt after having to pay the out-of-pocket expenses. And only 4% of people with chronic disease have their disease under control. And that is exactly what is happening today. And that is what we are even trying to solve. And I think more I will talk about as we go along, how exactly, because this is not just the theory that we are talking, we have been experimenting this model for the last 5 years, and there are a lot of learnings, definitely some of which that I would like to share with all of you, which probably kind of ignite some thoughts in all your minds that go back and say that, okay, if this is working, how can I also be part of it, and how do we change? Because private healthcare has done good for all of us for the last 40 years. And it is our responsibility to see how we can change and grow and do a lot of things in the future, and not continue to raise the cost of care by just focusing on sickness.
I mean, talking of something very important, clinical outcomes you spoke about. How many of you in this room are doctors or to be doctors? Okay, awesome. Just hold your hands. How many of you visited homes to treat patients? The number of shows have come down. So here's a difficult question, Dr. Rima, for you. I mean, patients walk into hospitals, the ecosystem is great. The only difference is, of course, the most difficult thing which should not happen is you get beaten up in a hospital if you're a doctor, right? That's a terrible thing to go through. But what it means to be getting into that patient's home and treating that patient in their ecosystem, what it means and what are the challenges that one faces, because that's going to be the future if we were to really get out of the hospital and try something out differently, right? It's the home. So what's been your most difficult, disastrous, challenging experiences driving these teams into homes, and what lessons you think you can give us as we go?
Great, thank you so much. Definitely a difficult question. See, there is a spectrum of care that we talk about, right? And every setup has its own expertise. When a doctor walks into any home, they are welcomed. But there is limitation to what a doctor can bring along with them to a home, beyond a PP apparatus, a sugar machine, and a few. Right now, we are talking about AI technology, etc. So there are portable items that can go in. But we are unable to convert that room into an OPD or an IPD. So those limitations are always there. So that is something that we need to be cognizant. But what are we achieving here? We are achieving accessibility to health. And does it mean it is as cheap as going to a OPD? It is not. I mean, I was in Japan recently, and when I checked into a hotel, I was given a business card. I think they do it as a process over there. For any sickness visit, if you want a doctor, fees, yens, 25,000 yens, which is 50,000 rupees of ours. I was shocked. When somebody is visiting you, they will charge the liver and the kidney. So those challenges definitely are there, and the customers, we have to talk about two things: accessibility, affordability, desire to pay. There are a lot of variables that move around. That satisfaction of doctor reaching a patient and doing a care is great. But what if there is something difficult and I needed something else? That's a disaster. And that happens. And then we get into that tailspin of calling the ambulance, calling the team, etc. Follow-ups necessarily, because we all know the number of doctors in our country are much lesser than what we require. So there are certain follow-ups which we make our senior nurses do. Senior nurses sometimes are not allowed beyond their gates. The gate pass is not given. So there are a lot of these issues. Doctors are yet considered as demigods till now, unless they are beaten up. But
we as doctors don't have an problem in accessing a home, but our teams do. And we always carry the limitation of the lack of resources and technology when we reach a patient. That is the biggest challenge that we have seen when we work in home care. Another challenge I will tell you from the quality perspective. We were undergoing this home care QAI accreditation, and one of the NCs that came to us, how do you monitor hand hygiene of a caretaker at home? How the hell do I manage that? I'm sorry for the language. I don't know. In hospitals, at least we have surveillance teams, etc. But at home, and if we have this QAI, everybody believes that this company seems to be reasonably okay because they are standardized, they are process-oriented. So these are very, very basic challenges that we face when we talk about homes. That is why we thought, let's bring the patient out of the home, not very far away to the hospital, but to a neighborhood care center that we create. So we can give them a slightly higher level of care. Accessibility is better. Affordability also becomes better because the cost comes down. So these are various evolutionary business evolutions that I must say that has happened when home care is concerned. So everything, your direct question to your, answer to your question, what are the challenges that we face when we go home, is the lack of infrastructure they carry with us.
Interesting. I was talking to a Nobel laureate who specializes in understanding human neuropsychology, right? I mean, neuroscience is why we do what we do, nobody understands as much as neuroscientists. And he was saying that the biggest barrier for us to get to homes is our inability to understand what the human behavior is going to manifest when you get to that home. That some homes accept you, welcome you. Some homes are not going to accept you. Some treat you as doctor versus non-doctor. So how do you even visualize all of this much ahead of time? How do you predict what the likely human behavior is going to show up before you even treat and care? So that's the interesting learning, and it ties well with you. Okay, now a big question, which has been, and that's the reason why I have him here. How many of you in this room, you think we have good medical device for the future that can be used at home? Nobody in the room. Beautiful. That's one of the reasons why you have it? You have a feeling? Are you strong about it? Can we have a mic there? How strong are you about that decision? First of all, applaud. There's one in the room who's feeling strongly about something. Yeah.
No, I've been feeling strongly about one or 2 points since the previous panel. Somehow I didn't get the mic to discuss my points, but I fully understand. I'm Dr. Roshan Christina, by the way. I'm an ophthalmologist. I fully understand that we have a very diverse crowd here, and we seem to have been discussing more about radiology and oncology and now cardiology. Now, I'm here standing for ophthalmology, and we do have our own challenges, of course. But some of these things that you all are discussing right now, in terms of going to the patient and having portable devices of good quality, and someone else earlier had mentioned about involving allied health sciences and ASHA workers. Ophthalmology is one specialty which has made headway in all of these things in terms of a workflow for decades now, and AI is really helping with all of this. In fact, I consult for Forest Health, and they are one of the pioneers, you'll have to go and read up about it, in making all of these devices available remotely to the last mile. So there is a condition called retinopathy of prematurity seen in newborns, and during my training, I've seen how difficult it is to, even if the patient is baby is in the hospital, it is quite a challenge to be able to go and assess, because it's because of the sensitivity of the whole situation. There's a newborn, there's a condition you don't want to miss, and then you have only few specialists who are trained in picking up things like this. Now imagine a company in India that has made a one-of-a-kind device for this. I mean, I'm sorry I'm going off on a tangent, but just for awareness, to pick up retinopathy of prematurity remotely. They've made a device. You don't have to come to the hospital. You can carry that device to any part of the world. In fact, we have Orbis, which is flying ophthalmology, OT and OPD. So including them, they have taken on to this device so well that we have a lot of possibilities in terms of taking good quality devices to the patient's home and remotely being able to get good quality reports for all of that. And that is something which has a lot of scope in ophthalmology. So
Awesome.
I have a little different opinion and I'm more positive about AI and its adoption in this field. And I think it would be nice to include more ophthalmology speakers henceforth in such AI-related, AI-related conferences. And there's something called Oculomics, which again is something tremendous with a lot of potential for the future. And oh, hi, ma'am.
Okay,
Pleasure.
here you go, quickly.
So I'm sorry, I took a lot of your time, but it's just been on my mind, like, why isn't anyone talking about this? There's so much of good here, there's so much, but I think we are a little underrepresented right now, but that's okay.
Okay, I'm going to ask this audience you to vote, okay? How many of you think we have an extended panelist who's sitting there and who got a chance to become a panelist right from there? How many of you think so? I think so. Did she give you a point that's important in life to carry forward? Yes, no? Please, round of applause for that. Really appreciate that. I mean, it ties so well with what Dr. Rima said. It's very difficult to get your voice heard and get your mic on. That's a reality of life. And she spoke about a doctor being powerful, whereas somebody who's non-doctor going home, not having the voice. Same thing here. I mean, give a round of applause for that intent, right? And you made sense to us, so you didn't digress us, so you literally answered on behalf of what Satish did. But I'm going to put him this difficult question which you asked. Okay, Satish, I got you in for a purpose. I mean, we do a lot of repeat work of, building the same box in a little different avatar, right? Same CT machine, a little cute looking. An MRI box, which looks a little more smarter. Question is, if this is the range of problems we are talking about, right? I mean, she spoke about a real problem of a serious sector or ophthalmology getting missed out in this whole device/whatever journey, right? How are you, as the head of R&D, thinking about the future devices? What's going in the thinking? Because what you're going to think and what you're going to bring alive is what is going to stay with us for the next 15, 20 years, right? And it's not what got us here. So how is your thinking and your team thinking about it?
Yeah. I mean, if you look at the MR that I saw 26 years back versus the MR that we have today, it's completely different. The things that it cannot detect or it wasn't able to detect before versus what it is able to do today in 26 years probably have quadrupled. Okay. And when I was talking about the accessibility, right? I mean, MR being MR, the physics behind MR, you can't move things out. It's heavy equipment. So how do we bring accessibility to more closer to where it needs to be? There are many very, very low field strength Tesla MRIs now coming up. And there's a company, I'm not sure if any of you know, Hyperfine, who has a MR, which is a 0.2 Tesla MRI, which you can take it to ICU just by rolling. I have been working with Utrecht University in Netherlands, developing a 0.025 millitesla field strength MRI for detecting stroke. And it can be installed on an ambulance. Okay. So the technology is disrupting. And this is what technology can do. So every vendor, forget about vendor, almost a lot of startups are also coming in terms of how best to bring MR closer to the patients and how best to make it affordable. A typical MR probably on average would cost anywhere between $800K US dollars to 1.2 million US dollars. The MRI that I just spoke, a 0.025 millitesla, is a 50K US dollars. So affordability and accessibility, these are the two things where we are focusing.
Interesting. Now, the serious question. I mean, how many of you are enjoying this conversation so far? Okay, you're enjoying. Okay. And I still promise you, you are our extended panelists, so you're also going to be part of it as we go. Okay? We're going to make life a little difficult. Do we make it? How many of you want to make their life a little difficult, little more difficult in the panel? Okay. I'm going to put this round, I'm going to actually swap the round to make it more exciting, and this possibly could be the most memorable round you're going to ever witness. It's a crossfire round. I'm going to put two people, of course, sorry for this. I know you already said dangerous. There's nothing more dangerous than putting and being honest about it. I'm going to take two people, put them on the spot, and make them feel uncomfortable and answer a question. And I'm very open to getting beaten up. Okay, here's Charit and Satish. Question for you. I mean, there is a device which detects, and there is algorithm which predicts. Between these two, if something gets goofed up in a remote town, who takes ownership of the goof up? Right? I'm not still going to the death of a patient. Who owns failure? The device company or the algorithm company? Fight it out.
Okay, let me go first. Fun question for sure, because this is something that we continue to debate even today in other forums. As long as the device company thinks they are developers of a device that produces data, and it's up to the healthcare providers, or in this case service providers, or doctors or radiologists, whoever, because finally they are the ones who are making sense of the data. The machines do not directly create sense as of today, but it's not far that it also will start making sense. So the in-between gray area that you just mentioned, according to me, the medtech device providers, they think that the service providers, which is in this case doctors and radiologists, or whoever they are, who finally says that this is what it is, they have that accountability.
Interesting. Okay. The doctor.
It's a slightly different point of view.
You are also the service provider, by the way.
So I'm going to give you an example of TriCog. Now, what we do is enable ordinary doctors at the most remote corners of India to diagnose a heart attack. And this is how we do it. We give them a device that captures data of the patient, an ECG, uploads it to the cloud. Our AI produces the first level diagnosis, identifies 140 different heart conditions, followed by which there's a medical team of 120 doctors who work with the AI, verify what that output is, and that report goes back to that doctor in 6 minutes' time. Now, to do all of this in 6 minutes is where the AI has come through. Now, what liability do I hold? And this is a question that I've asked myself now since 2009 when I started this journey. And the answer is quite a bit. That doctor, and it could be an MBBS doctor, it could be an Ayurveda doctor, relies on what the report is coming to decide the treatment of that patient. So I hold the responsibility to ensure that that loop is done and done correctly. And to our previous panelists who were talking about AI, so when we started in 2014 and incorporated the company, AI was not a buzzword at that point of time. And that has grown as the core IP in our company, that today the failure rate for us as far as AI is concerned is that we miss 3 patients per 1 million patients that we see. So we screen approximately 1 million patients every single month. And there are 3 that the AI misses. And this is the reason why we have a team of 120 doctors, so that those 3 patients, and those 3 patients is somebody's father, mother who's having a heart attack and whose diagnosis is going to be missed. So my responsibility is not to duck the liability, but to say, hey, that person out there in that corner of India is using TriCog. How do I make sure that I give them the best possible report? So the responsibility, of course, medico-legally, the responsibility rests with the treating doctor. So that's what the legal contract says. But all of us from the medtech space bear this responsibility to ensure that we know where our technology fails. And it fails a lot. When we started in 2014, the turnaround time was 10 minutes because the AI was all over the place. And with only more training data, the turnaround time from 10 minutes has gone down to 40 seconds. So I bear the responsibility of making sure that that report is accurate. And that is a responsibility that each of us must embrace and make sure we do justice to those patients who are there.
Okay. There's a second crossfire we should do, and it's an exciting one. I was waiting for this the most between Dr. Reema and Dr. Chandrika, this crossfire. I hope you fight it out. Hospitals, you get admitted, 5 lakh treatment fee, no problem. Home continuity, 5,000 per week or 5,000 per day, people are unwilling to spend. When home care, which is needed, is not getting the right spend that it deserves, how do you think preventive insurance will work? And if you say it does work, then I want Dr. Reema to contest and counter. And if you think it's working, then I'm happy. I'll leave this place with a sense of joy.
Today it is not working, definitely. But, whether I am a pro about this, definitely we are. That is exactly what we are trying to do at EVEN. Because, today the insurance works on the group level risk. Right? And they don't consider spending 5,000 rupees on preventive check as an investment. They consider that as an expense. Whereas paying that 5 lakh rupees ICU bill is already factored into their model of risk and the way they do their business. So they are actually waiting for that incident to happen. Right? Because that is how their business model works. So definitely, having a preventive mindset is very important, and spending that 5,000 rupees on a person to encourage primary care and preventive care is the way forward. And insurance has to work like a partner in people's healthcare journey, rather than claim processing unit. Today, they are glorified claim processors. They are not worried about people's health. They say, okay, here is your sick bill. How much can I reduce? How much copay are you going to pay? And how much I can settle? So that is where the thought process ends. So it is very important that we change that mindset, and insurance becomes more of a partner rather than just a payer. And of course, invest in primary care is very, very important. And that is where the AI also plays a major role as well in scaling up the primary care.
Awesome. So we have a time up. We will end with Dr. Reema and then get to the audience.
Sure. I think Dr. Chandrika has she's on my side. But I would definitely take this opportunity to mention about, what they are doing is really, really amazing. We as care providers have been looking out forever, speaking to insurance companies forever to cover people beyond 70. There are a few insurance companies that are doing that, but there are a lot of no's rather than yeses, part number 1. 2, it's only acute episode which is covered. So the companies don't mind spending or giving away 10 lakhs, 20 lakhs of bill, rather than like people like us, when it is rehabilitation outside a hospital, one episode in the hospital will cost 10 lakhs, but in a place like ours, it'll probably cost 1.5 lakhs per month. That is not covered. So this dichotomy that we keep telling that why is that you can't prevent? Because if this person does not undergo rehabilitation process, has a high chance of readmission and refall, there is So in the sector that I work in, we largely work with not prevention of conditions, but prevention of the next episode. How are we funding this is what we need to answer, right? So chronic care also needs to be looked at from the insurance sector. What is that we can do to reduce the burden of the insurance companies as well as of the payers? Instead of spending 20 lakhs, can we spend a lakh per year? I understand. I have also worked in the insurance sector, and there are a lot of ifs and buts that they come out with. But when we talk about future, when we talk about intelligent minds coming together, is that this such a simple solution we can't get together and have it? Of course we can if we want to.
Thank you. I think I've done my job of putting them in uncomfortable situations and hard things about hard things, ask the difficult question. We will take one question. We're already running late for the next panel. Let's take one question and then, let me give it to you.
So we talked through about the wellness, the preventive care, and also you have called out like we may download the couple of apps and within 3 days, or it just goes unused, right? So one major thing that we have observed over time, by the way, I'm working in Kerala as a product manager in the behavioral health sector for almost 6 to 7 years. So now one thing that what we have identified is kind of an habit building, which is missing today. Even after the diagnosis, the people may not be able to adhere. So with the digital evolution that we have and the AI that we have today, in terms of the wellness preventive, what can we do to bring up this habit building,
So when we started even 5 years back, all of us know, right, in India, OPD is not covered by insurance. So we kind of developed a product where we gave unlimited consultations, teleconsultations, physical consultations, diagnostic. So one question that people always asked is, will that not be abused by people, right? You're giving it everything like, free cover, everything is covered. So to our surprise, it was not abused. So people find it so convenient to talk to our doctors. 80% of the time, we are able to solve their problem through teleconsultation. And only 20% of them actually need a physical face-to-face consultation. And we are able to diagnose their problem early, intervene early, so that their cost of care also comes down. And we have seen that time and again last 5 years, and it works wonderfully. So it's all the intention of doing it and covering the primary care from insurance perspective, and you can really do wonders in primary sector.
Got it. Thank you so much. In the interest of time, I would not summarize. I assume each one of us are small language models. We know how to summarize for our own self what we take from here, and then possibly run a conversational question within our own self and then have answers. And the success of each one of our models will tell us what we're going to participate with. Thanks a lot to this group. A round of applause for being unfiltered. And I hope you don't beat me up once I get out. And I also want to welcome our extended panelists to come over here, right there, the ophthalmologist. Join us. You're also a panelist. Yeah. So it's been a great time. Please ask questions and the difficult ones. I want to read Hard Things About Hard Things by Ben Horowitz. It's great. I want her to come over right here. Come over. You're also a panelist. They accepted you as a panelist. So, please come over. Please come over. Come over. It's a photo for us. I mean, how many moderators have the privilege to have an extended panelist join us?
A big thank you to our moderator and panelists for such an engaging and insightful session.